home. And if you've seen how a water cooler looks like, you have to feed in water to the cooler and then the air comes out from there. So there is some amount of water which is there inside the cooler which can get contaminated with certain fungi or bacterial infection, which, if you do not clean, you do not sterilize, you do not change the water that much, might end up in having a lung exposure to
some antigens.
antigens. Yeah. So, would you like to tell us something more about this? No?
No. Would you?
I just like to mention that if we suspect ILD, so the first investigation usually is a chest X-ray, but we have to note that only many cases are normal. Basically, 10% of normal chest X-ray may mean the patient has an underlying
So,
disease.
we see that now.
Yeah. So what I feel is that since CT is quite widely available, so CT scan should be the basic investigation and not only the chest X-ray, because it's, I think, about 90% sensitive.
So, a radiologist is speaking
For
on
HSCT
your
also.
behalf, and no, there's nobody in my behalf. The audience is silent. So, this was a case of hypersensitivity pneumonitis due to some exposure to antigens, mostly fungi and bacteria, in the cooler.
Water coolant.
So, if we look at this patient of a 61-year-old male, breathing difficulty for 2 weeks, which gradually worsened, a low grade fever for 2 weeks, smoked 10 cigarettes per day for 40 years. Morning stiffness and arthalgia were not observed in this patient, and he did an office job which involved desk work only. On physical exam, the vital signs pulse was 136 beats per minute, respiratory frequency 42, BP 129, temperature raised, mildly raised. Chest had bilateral crackles on auscultation. The JVP was not elevated, no pedal edema, no clubbing fingers. Chest X ray performed on the first visit revealed no significant abnormality. That's Dr. Das.
Normal.
And when Shondip did a CT scan, this is what it showed.
This is the inspiratory high resolution computed tomography, which shows diffuse centrilobular ground glass nodules with faint margin. We barely just the margin are not so clearly well delineated, and there are patchy density differences also there. That's called mosaic attenuation, and it is distributed throughout the lung. No gradient is there, so that is also another point for our diagnosis when we reach the diagnosis. And this always says that this is an infiltrative interstitial lung disease, and coexisting small airway disease is also there. And after some medicines given by Dr. Ongira, this is the resolution.
So we've managed to resolve all the opacities in this
opacities.
CT scan, and why do I have to give the answer?
Because we can't treat.
You can't treat?
We just diagnose.
Okay, so since we have done the good job,
Yes.
this is what we found when we revisited the history. 2 pigeons sitting inside the room. So when we put all this information together, acute hypersensitivity pneumonitis was the second case, whereas the chronic one was the first case. So would you like to take us through
Yes, yes. This is the hypersensitivity flowchart where the upper end mid-zone predominance is there, and these are the GGO and centrilobular nodules and fibrotic changes, traction bronchiectatic changes, and these are all air trapping. Some good images are also there. Previously, it is used to call head cheese appearance. These are all scavenged meat from different sources, like from pig, from duck, from cow. From these are all these called head cheese appearance, because the three density pattern we can see in the HSCT chest. This is the normal lung, this is the air trapped lung, and this is the GGO. These three signs, this is called three density sign, which is the diagnostic of this disease. And these are some pictures, typical non-fibrotic HP. Right now we diagnose the HP, just classified is as non-fibrotic and the fibrotic HP. The first case was fibrotic HP and the second case was non-fibrotic HP. And these are all the finding, the yellow arrow, these are all air trapping, and these GGOs are there. And this is the typical fibrotic HP where fibrosis, traction bronchiectasis, and GGOs all are there. Next, our next.
Okay,
third
so I think we need to progress a bit
progress,
fast.
rapid.
Yeah. So this was an 45 years old gentleman who was asymptomatic since 14 years of age. Engineer, never smoker, visited construction sites occasionally and always used personal protective device. Cough, scanty expectoration, wheezes, asthma, MDI, allergy not known but very frequent, rhinitis. So this is a case of a typical allergic rhinitis which was progressed to a asthma. Current symptomatology was again some low-grade fever, some hemoptysis, exacerbations which responded to corticosteroids in 10 to 15 days. But very fortunately, he did not need much of an hospital admission during that time. Blood imaging, lung function. So I think that should be the dictum for all patients we see in the ward. Yeah. X-ray.
The chest X-ray shows increased bronchovascular markings. The bronchovascular markings are a bit prominent. We don't see in this age group so much prominent bronchovascular markings. And that's what we can make out from the X-ray.
Okay. Moving on, we did a spirometry. This is a reversible obstructive disease, which means that the patient had asthma. When we tried to do a phenotyping with the blood work, so it shows that the eosinophils are 3% and Ig is also a bit raised. So how do we treat this patient? Step 5 GINA guidelines. That's a lot of inhaled corticosteroids and bronchodilators, add oral steroids and biologics if required. However, this patient kept on having multiple hospitalizations, and investigations showed
the chest X-ray HSCT chest of the axial section shows central cystic bronchiectatic changes, which we can make out. These are all central cystic bronchiectatic changes, and also some ill-defined centri acinar nodules are also there. And these are all nodules we can make out.
So there are certain diseases which does not cast an opacity in the chest X-ray. And the one to remember here is that airways. Airways disease do not cast any abnormality in the chest X-ray. This is a closer look at what we have already described. Now, if you see a X-ray like this with a history like this, the three main, and I think the only three differentials here would be TB, atypical mycobacteria, bronchiectasis. So when we did an allergy panel for this patient who had a raged IgE, it was positive all through. But the patient still kept exacerbating and required multiple hospitalizations. And because the fungal sensitization values were all positive, we tried to treat the patient with voriconazole, and lo and behold, this is what we saw.
So after the voriconazole therapy, the prominent bronchovascular markings right now is a bit lesser in number, but still is there. So there is some.
But the main things have cleared.
Yes, the main problem.
So we went one step ahead and did a serum beta-galactomannan, which was positive. Aspergillus fumigatus IgE, specific IgE, positive. So we put in a diagnosis of ABPA in this patient, and
And this is the typical X-ray finding, which this finger in globe appearance. These are the central cystic bronchiectatic changes which we are there in the CT scan which we saw, and this is the X-ray finding of the central cystic bronchiectatic changes. And this finding is called finger in globe appearance in the X-ray. And these are some complication of invasive aspergillosis. This
So
called
when a
the
patient does not respond
respond
to
to the
ABPA,
voriconazole
yeah,
and,
so voriconazole, steroids,
steroids,
and all the supportive
all the
care,
supportive.
what we are supposed
Then
to
we have to
consider is whether or
Sir?
not there is some amount of
Invasion is there. invasive
invasion
aspect.
is there. Yeah.
So these are the haloshine, and this is the fungal ball, and this cushion shape is the air, and this is the cavity, and this is the fungal ball. So it's an invasive aspergillosis. This X-ray or CT scan.
So we'll leave you
Thank you.
here with the thoughts that even if a pulmonologist is alone all by myself on one side of the stage, they are my friends all the same. Thank you very much. and Thank you.
Thank you for the
audience.
patient hearing.
Thank you, Ongira and Sandeep. It's just excellent coordination, and that's what's required in real life. Usually, because most of the lung disease, they have they need X-rays and CT scans for good diagnosis. And yeah, exactly. And the coordination and the understanding that you both showed, this should be followed also in real life between radiologists and pulmonologists, so that the diagnosis and the treatment and the patient comfort that actually helps. Thank you.
Thank you. Thank you.
That was an excellent session, no doubt. I think the best till morning. Perfectly coordinated. So I'll request our speakers and the chairpersons to kindly proceed towards the memento corner and collect their mementos. And we will be moving on to our next session, that is rewriting metabolic script. And our speakers are Dr. Indira Maisnam, Dr. Mounam Chattopadhyay, Dr. Shormishta Mukhopadhyay. Are they here? Please come to the dais. And our chairpersons will be Dr. Sanjeev Ghoshal and Professor Dr. Ashish Basu. I'll request our speakers and our chairpersons to kindly come to the dais. Dr. Mounam Chattopadhyay and Dr. Shormishta Mukhopadhyay. Okay, she will be joining because she is the last speaker, so she can have her lunch and come.
At the outset, that is paucity of audience. Let the audience come because
actually, we have a running lunch, so there won't be any.
because this is a very interesting.
I understand, but we cannot help.
Okay. So at the outset,
I'll request the audience, please come forward. So at least that will look crowded in the front. Please, all of you come forward. Leave the first row and you sit. Shormishta, you please come to.
At the outset, I deeply express my sincere gratitude to the organizers for inviting me to be a part of this academic bonanza. It's really a sort of homecoming and nostalgic feeling for me because I had my early some 5 years of about 5 years of professional career at B.R. Singh Hospital. So it's a very nostalgic sensational feeling for me to be on the podium here. And I was then mentored by Dr. A.C. Kundu, Dr. Yogi Mehrotra, Dr. T.D. Bhattacharya, and Professor M.K. Chetri was the visiting consultant. So actually, I am grateful to all of them. So today, after sumptuous, the lunch, the session is also a bit equally sumptuous academic feast. And we have three brilliant speakers from the enchanting endocrine world. Three brilliant speakers rewriting the metabolic script. So the first speaker, Dr. Indira Moshnam, all are very brilliant in their own way. And so I invite Dr. Moshnam to start her deliberation.
Thank you,
Thank
sir,
you.
for your kind words. Thank you, the organizing committee of the Indian Railways Health Service Association, for inviting me. So my topic is why obesity is a chronic disease. So these are the disclaimers. So if we look at the obesity epidemic and its prevalence, it is prevalent all over India, as we can see, and 4 in 10 women in India are affected by abdominal obesity, with many exceeding the recommended waistline, whether it is in the north, south, or west or east of the country. So many factors contribute to the obesity. The number one factor is the genetic factors, but along with it, there are factors like epigenetic factors. Epigenetic factors are influenced by environment and lifestyle. The genetic expression is being affected. Environment, social, cultural, physiological, and behavioral. Now, neuronal and hormonal communications modulate both food intake and energy expenditure. So the peripheral signals are received by the CNS, and then it is managed by the hypothalamus. So if we see, the appetite has got a homeostatic eating, where, let's say, when there is a deficit of calorie, there is increased appetite, there is decreased satiety, and there is decreased energy expenditure. And the opposite happens when there is energy surplus. But over and above this, there is also the hedonic eating that has nothing to do with the homeostatic balance of the body, but just the pleasure of eating. And again, there is the prefrontal cortex, which executes the function and either makes the person eat or introduces some inhibitory actions so that the food is not taken. And if you look at the number of satiety hormones, there are lots. So a lot of them are released from the intestine, whether it's the GLP-1, the CCK, the GIP, or the peptide YY. Adipose tissue, also the leptin decreases the appetite, whereas from the pancreas, the amylin and insulin also decrease the appetite. But the hunger hormone is secreted from the stomach and is a ghrelin. So adipocyte dysfunction is a key driver of adiposity related complications. So healthy individuals have normal adipocytes, but in obesity, the size as well as the number of adipocytes increase. So when the size of the adipocytes increase, which is known as hyperplasia, it becomes more dysfunctional because of many mechanisms. And the dysfunctional adipose tissue leads to, firstly, it releases a lot of inflammatory cytokines and leads to the release of ectopic and visceral fat accumulation, and which can overflow. In other words, the fat from the subcutaneous adipose tissue overflows at other sites, whether it's the epicardium, the pericardium, the liver, the kidneys, in between the muscles, intermuscular, mesenteric, or mental, etc. And as I mentioned before, this dysfunctional adipose site and also the dysfunctional adipose tissue results in the release of a number of cytokines, which worsens insulin resistance. So excess adiposity and the sick adipocyte, that is the adiposopathy, are the key components of the obesity disease, all accepted by all the major authoritative bodies in the world. Now, maintaining weight loss is a challenge because the body's compensatory mechanism favor the weight regain. Because when there is a weight loss, the homeostatic mechanism, something what is known as the defense of the body weights, try to actually bring back to the body weight to the baseline, which could be higher and which the body falsely believes to be normal. Because when there is weight loss, there is decreased energy expenditure, there is increased hunger, and decreased satiety. So it is not a measure of just a lack of self-control, but a mechanism in the body that actually promotes weight regain. And the increased drive to eat and the decreased energy expenditure resulting from weight reduction create a perfect physiological storm for weight regain. And therefore, if we look at the obesity treatment guidelines, we have guidelines by many societies, whether it's the Endocrine Society of India, the American Association of Clinical Endocrinologists, the Obesity Society, so many have guidelines. And in the context of India, what we need to know is that we have a lower cutoff for obesity, so that a body mass index of more than 23 kgs per meter square is overweight, more than 25 is obesity, waist circumference of more than 90 centimeter in men and 80 centimeter in women, or sometimes we take the waist hip ratio. And if we have the facilities to measure the body weight fat percentage, either by means of a DEXA scan or by other mechanisms, in that case, a body fat percentage of more than 25% in men and 30% in women is considered to be diagnostic criteria for obesity. And we also need to remember that obesity is a chronic relapsing progressive disease defined as mentioned by excessive adiposity that may impair health. And beyond and above the mentioned convention, above this, there are also other measures like the waist height ratio, the neck circumference, etc. So if we again look at the clinical indicators for obesity, it could be staged as like the Edmonton Obesity Staging System. The Edmonton Obesity Staging System is based on the Canadian Obesity Society. Even the Endocrine Society of India has staging system where, depending on the stage, that is 0 to 4, what type of treatment modality should we follow is decided. So if there is no apparent risk factors, then just primordial prevention. But if there are subclinical risk factors, for example, let's say the person has a sedentary lifestyle, unhealthy dietary habits, then it is a primordial prevention. But then if there is established obesity, then we need to see whether the established obesity is associated with obesity associated complications. And if it is associated with obesity associated complications, for example, let's say diabetes, then we have to see whether there are end stage complications, for example, end stage kidney disease because of diabetes. Then our treatment approach changes from primordial to primary to secondary to tertiary. And the guidelines recommended that we should have therapeutic goals to treat obesity. So the EASO, that is the European Association for the Study of Obesity framework, recommends developing therapeutic goals based on severity and stage of obesity. So the staging of obesity depends on the presence of complications and the extent of complications, while considering prevention for further weight gain and obesity-related complications. Even the AACE has said similar things, and obviously our treatment of people with obesity should be individualized. So the American Association of Study of Endocrinologists suggests that the term obesity should be replaced by adiposity-based chronic disease, or ABCD, because then if we use this term, it identifies obesity as a chronic disease, and it alludes to a precise pathophysiologic basis, that is adiposity, and avoid the confusion associated with the term obesity. So the management of obesity, whatever the BMI 25 and above in our country, the number one thing is lifestyle modification. Now, pharmacotherapy is advised when the BMI is more than 27 with adiposity-related complications. Let's say somebody with type 2 diabetes with a BMI of more than 27. Whereas surgery is indicated when with a BMI above 30, when other interventions have failed. That is, let's say whether pharmacotherapy has failed, patient has done significant lifestyle intervention. In this case, bariatric surgery or metabolic surgery may be done. And all individuals, regardless of body size or composition, benefit from a healthy, well-balanced eating pattern and regular physical activity, which should be a mix of both aerobic as well as strength training or resistance exercise. So lifestyle therapy includes two major components, that is the diet. Advise a hypocaloric individualized diet. So it should be low in calories because that will cause weight loss, but it should be a nutritious diet. That means it should consist of complex carbohydrates, high-grade protein, lots of fibers, minerals, vitamins, etc., in the form of fruits and vegetables, and let's say good quality protein. And physical activity, at least 60 minutes of physical activity, aerobic and resistance exercise daily, or 300 minutes of activity per week. And also at least, I would say that it is 60 minutes of physical activity aerobic daily, and at least 3 days of resistance training exercise, which should not be done on 2 consecutive days. Now, lifestyle intervention programs like the diabetes prevention program showed that minimum weight loss of 7% body weight through dietary intervention can take place, and there is a 58% reduction in the incidence of diabetes with 150 minutes of moderate intensity physical activity. But the problem is that there is the, like I said, the defense of body weight. So following weight reduction, most is regained over time. So when somebody loses weight, they could lose both adipose tissue as fat as well as muscle. But when regain takes place without physical activity, the regain would just be uh, adipose tissue or fat. So the assertion that lifestyle modification, including dietary changes, alone are insufficient for maintaining weight loss can be supported by scientific evidences. And following weight loss, there is a change in the hormonal pattern. If you remember that all the satiety hormones and the hunger hormones, there is a reduction. There is a reduction in the satiety hormones, whereas there is an increase in the ghrelin or the hunger hormone. So and also there is a decrease in the energy expenditure by the body, and thereby it is very difficult to maintain weight loss with just lifestyle modification. And here comes the role of pharmacological therapy for obesity. So these are the pharmacotherapy for obesity. The reasons for the pharmacotherapy I have already mentioned. So to mention some important agents, tirzepatide, which is a GIP and GLP-1 receptor agonist, which actually causes very significant weight loss. The starting dose is 2.5 milligrams subcutaneous once weekly. Every 4 weeks, you could increase by 2.5 milligram, and the maintenance dose is 5, 10, or 15 milligrams subcutaneously as the patient needs and tolerates. And it is maximum dose is 15 milligrams subcutaneous weekly. Administration is once weekly, and the injection sites are like those we have for the insulin, because it is in the subcutaneous site, and it is injected without regards of the time of the meal. There are other agents like semaglutide and orlistat also, which are approved in our country, but tirzepatide as of now is the molecule, because of its dual target of action, has got the single highest greatest weight reduction in people with obesity. And there are many forms of metabolic surgery, and the indications are in those with a BMI of above 30 with complications. And these are the different modalities of bariatric surgery, where we can see that the maximum weight loss is seen in the Roux-en-Y gastric bypass. So to summarize, obesity is a complex chronic disease requiring personalized management to address serious implications and challenges. So many authoritative bodies like the WHO, the American Medical Association, officially recognizes obesity as a chronic disease. The prevalence is very, very high all over in the world, including our country. It is a complex pathophysiology of genetic, epigenetic, environmental, socio-cultural factors. Management, definitely lifestyle is there, and also that which includes dietary intervention and physical activity, but that is not sufficient in many of the cases, and that is why we need pharmacotherapy for obesity. And there are challenges in maintaining weight loss, which can be at least addressed to a significant extent by the modern pharmacological agents for obesity, whether it's tirzepatide, semaglutide, or by bariatric or metabolic surgery. Thank you.
And thank you, Dr. Indira, for your enlightening discussion. We'll take up comments or question at the end. So you please take your seat here. Our next speaker is another erudite speaker, none other than Dr. Mounam Chattopadhyay. He will take us to the sojourn of diabetes and the treatment with one molecule, rather magic bullet. So let us hear from Dr. Mounam about the magic bullet. Over to Mounam.
Respected Chairperson, sir, my fellow speaker, ma'am, and respected delegates. At the outset, I must sincerely thank the organizers for having me here. Now, today's topic of discussion is diabetes and obesity, and text has already been set by my prior speaker, Dr. Maisnam, that GLP-1 receptor analog as a group could be a wonderful choice to manage both the diabetes and obesity by a single molecule. as a preliminary discussion, we must acknowledge the fact, and it's quite clear that obesity is a chronic progressive disease which is affecting a huge amount of people all over world. Around 1 billion people are supposed to be affected by diabetes worldwide, and the maximum burden is being burnt by the developing nations, strangely. India, our country, is no exception. India houses a huge number of obese individuals, and centripetal or abdominal obesity happens to be the commonest variant of obesity in this part of the country. Now, with obesity comes numerous complications, around more than 200 plus complications, and it could affect almost every organ system of your body, and which could call for almost every medical specialty to get involved in the management of obesity. Although with advancement of treatment, the overall mortality and morbidity is coming down, the cardiovascular mortality that is specifically related to overweight and obesity, that is found to be increasing by leaps and bounds. This is the most striking phenomenon, and it actually rings a bell that how we should be more proactive in management of overweight and the state of obesity as a disease. Now, what are the merits of weight loss? With progressive weight loss, you can accrue several health benefits, not only metabolic, but more to it. If we graduate the weight loss into three categories like 5%, 5 to 15%, and more than 15%, with initial 5% weight loss, you could see that there is a remarkable increase in the insulin sensitivity in the liver, by liver triglyceride levels going down, and the beta cell functions improving, peripheral muscles, they are improving when it comes to insulin sensitivity, and the peripheral adipose tissue stores, they are also improving so far as the insulin sensitivity is concerned. With ongoing weight loss, like 15% or 20, effects are accentuated to a greater extent. Add to it, there is modulation of genetic expression in the subcutaneous adipose tissue, and further reduction of the inflammatory markers that aggravate the inflammatory cascade in the tissue levels. So, as ma'am has already discussed, that with diet and lifestyle, we could gain a good amount of weight loss that is beneficial to us, that is 3 to 5% of the weight loss. Maybe at times 6 to 7% weight loss is also possible. But for more amount of weight loss, we need something more. So we have certain, before the advent of these wonder drugs, we have invasive procedures like endoscopic surgeries, bariatric surgeries, which could give us a huge amount of weight loss, like 25% weight loss, 30% weight loss. But most of the patients, they find it unwanted. They are not interested for it. So in between area, this gray area of 15 to 20% of the weight loss, this question was unanswered. And the patients who fail in their diet and lifestyle management, in addition, who either do not fit the criteria for going for invasive procedures like bariatric surgery, for them a pharmacotherapy was needed. That was the need of the hour. So from this question, the research evolved, and we arrived with certain pharmacological agents like GLP-1 and GLP-1 GIP dual agonist. So in this vein, let me introduce to you semaglutide molecule, which is available both in oral and injectable form. But today, due to paucity of time, I will mainly focus on the newer injectable version. Semaglutide is nothing but an analog of human GLP-1 molecule. It has 94% homology to it, and the half-life of injectable semaglutide is around a week. So that is remarkable. That will require once a week injection, once a week shot. That is also good for patients, right? So it actually acts on the hypothalamus and on the posterior part of the brain, where there is area postrema and nucleus of tractus solitarius, which takes care of mainly two pathways. One is your homeostatic part of the hunger, that is the amount of food you need to meet your daily caloric expense. And second is the hedonistic pathway, or is the pleasure eating. So the extra amount of food that you go on eating beyond your hunger is suppressed, just for the look, just for the texture, just for the flavor. So this pleasure pathway is obliterated by this semaglutide, and so the vicious cycle has been broken down. Thereby, it reduces the body weight. So, what are the evidences behind this semaglutide of bringing down the body weight? There are a host of trials. All the baseline hypothesis was same. So, they are grouped under step trials. So, say there are several versions of step trials from 1 to 11 in different context and different scenario, like semaglutide compared with placebo, semaglutide compared with diet and lifestyle, semaglutide in certain risk group population, semaglutide withdrawal, semaglutide for a long duration, semaglutide in diabetes and pre-diabetes. So there are several versions. I am not going into the detail. In all the trials, the semaglutide was started as a once weekly injection, starting from 0.25 and going by the gradual increments from 0.25 to 0.5, then 1, then 1.7, and the optimum dose of 2.4 milligrams. So what they have found is the mean weight loss that the trial participants they have achieved is more than 15%. So as you can see, 18.2% was the mean weight loss with semaglutide 2.4 milligram once a day. It is near about that level in almost all the step trials. 75% of the individuals they have achieved 10% weight loss, and 50% of the individuals they have achieved 15% weight loss, and 30% even in controlled situation in trial population, so they have achieved more than 20% weight loss. So this is a theoretical projection, although it's not available right now. Increasing the semaglutide dose and reach 7.2 milligram, then the weight loss could be to the tune of more than 25%. Only time will tell whether it is achievable or when the patient can go on with this weight loss. Now coming to the second part of the story, that the diabetes or the metabolic part. So beyond weight loss, semaglutide gives you certain advantages, like the body shape that is changed or the inches loss. So the trials gave you a 16.3 centimeter reduction in the waist circumference. Systolic blood pressure came down by 10.9 millimeter of mercury, diastolic by 5.3 millimeter of mercury. The triglyceride, the lipid stores, they come down by 22%. The HbA1c reduction was 1.9%, and the CRP or the inflammatory marker that also came down by more than 60%. So these are the pleiotropic benefits of the molecule beyond obesity and even beyond diabetes control. So as I was mentioning, the 10th version of the step trial, step 10, they included pre-diabetic individuals, and they have shown that more than 8 out of 10 individuals who had a baseline pre-diabetes, they showed us that reversion to normoglycemia was even possible. In step 2 trial, the diabetic individuals were included. Their mean baseline A1C was hovering around 8.1%. 82% achieved the A1C target of 7%, and 72%, that is more than 70%, achieved the A1C target of less than 6.5%. Now, after the step trials were done, researchers were eager to see whether the molecule was having cardiovascular safety or rather cardiovascular benefits. So one dedicated trial was done for the semaglutide, which is a dedicated CVOT trial with around 500 patients recruited from India, which is of quite importance to us. So it showed that there was 20% reduction, more than 20% reduction of the cardiovascular risk so far as the semaglutide 2.4 milligram is concerned. So this remarkable success of semaglutide led it to the label update by the CDSCO, so which is the only GLP-1 receptor analog which is so far available, that is indicated to reduce the MACE events, including CV death, non-fatal MI, and non-fatal stroke in adults with established CVD who are either overweight or obese. Another important factor that I would like to draw your attention of the august audience is that the separation of MACE curves, as you can see, was quite evident before you attain the maximal weight loss of 15 to 20%. And 80% of the MACE risk reduction was achievable by factors which was beyond those contributing to weight loss. So with GLP-1 receptor analog, there might be certain other molecular mechanisms, some other genetic or epigenetic modification that's occurring in the controlled scenario, which might lead to the additional cardiovascular safety property they are imparting. So these findings of this CVOT trial was also replicated in some real world setting where the revised MACE3 criteria was employed, and semaglutide was compared with placebo as well as fellow GLP-1 receptor analog, fellow GLP-1 GIP receptor analog like tirzepatide, and it has shown that it has outpassed the other molecules and placebo. This happens to be another only one GLP-1 receptor analog molecule that is also approved in the metabolically associated steatotic liver disease in active hepatitis also, and it has been approved as an additional indication by the new drug application for non-cirrhotic MASH with moderate to advanced liver fibrosis, that is F2 and F3 stage, where it reduces the liver enzyme levels as well as there is reversal of biopsy proven fibrosis in the trial. So to summarize and conclude, semaglutide has been extensively studied in multiple trials. As you can see, there are lots of step trials that are available for your perusal. So it has been studied in more than 50,000 people in different trials. If you include also the oral semaglutide pioneer trials, these are also available. The safety profile is consistent as a class. There was no added adverse effect features. Just a few seconds. Only adverse events that were reported were GI related adverse events. So to summarize that, it is the only anti-obesity medication that we can think of in using in our day-to-day life, particularly in patients who are overweight or obese, and for those patients who are having cardiovascular disease or having MASH. So it could be an invaluable option for them. So with this, thank you. And that's all from my end. Over to the chairperson, sir.
Thank you. Thank you, Dr. Mohan Chattopadhyay. Now you'll proceed to the next topic, metabolic dysfunction associated steatotic liver disease. By now, the speaker is none other than Sharmishta Mukhopadhyay. She doesn't require any further introduction. I'll request her to start the deliberations. Thank you.
Too slow. Good afternoon, everyone. Respected DGRHS sir, respected PCMD sir, and respected chairpersons, all faculties and delegates. My topic of discussion today is metabolic dysfunction associated steatotic liver disease, an overview and recent advances in management. I will basically start from the point where Dr. Monam Chattopadhyay ended. So let's start with a case. A 56-year-old male office executive, he complains of fatigue for last 6 months. He is a known case of type 2 diabetes for 8 years on glimepiride 2 milligram and metformin 2 gram, with hypertension for 4 years on amlodipine, dyslipidemia for 3 years on rosuvastatin. He denies alcohol consumption. He has no history of prior liver disease, hepatotoxic drug intake, substance abuse, but he has a weight gain of 10 kg over past 5 years. You can see his physique in the cartoon, and his BMI is 32 with waist circumference of 104 centimeter, BP slightly to the higher side, 142 by 88, HbA1c 7.2, fasting sugar 134, with a little high TG 212 and HDL 38, with other parameters of lipid profile normal.
ALT and AST both are high, 68 and 52 respectively, with a platelet count of 1,50,000 and serology negative. Now we will look into the fact how this patient will be approached later on. Let's now look into the epidemiology of fatty liver. Fatty liver is basically a silent epidemic. Globally, its prevalence is 25%. In India, the prevalence is much higher. It is around 38.6% because we are basically carbohydrate loving population, and more carbohydrate causes more fatty liver. And surprisingly, the young children are affected here with a prevalence of 34.5.4%. So there is a change in the nomenclature from non-alcoholic fatty liver disease to metabolic dysfunction associated steatotic liver disease in last couple of years. So this change of nomenclature is basically the reflection of a paradigm shift in concept. Previously, we were focused on the presence of or absence of alcohol intake as a cause of fatty liver, but now we are more focusing on the metabolic factors as an etiology on one hand, and on the other hand, we are also emphasizing on its outcome, which is not only on the liver, limited to the liver, but also to other organs also. Like the fat in the liver is the earliest indication of fat elsewhere, that is the coronary atherosclerosis and cerebrovascular disease. So to define metabolic dysfunction associated steatotic liver disease, it is more than 5% hepatic steatosis plus at least one cardiometabolic, namely BMI more than 25 or in Asians 23, waist circumference more than 90 and 80 in males and females respectively, fasting plasma glucose more than 100 on 2-hour PP more than 140, BP more than 130 by 85 or on antihypertensive, TG more than 150 milligram per deciliter or the HDL less than 40 in males and less than 50 in females, or if the patient is on lipid lowering treatment. It is slightly different in pediatric population, but our focus will be today on the adult MASLD. So there are further classification. What I am wanting to emphasize is that you can see that a minimal amount of alcohol intake is not a bar for stamping the patient as MA. Even moderate to heavy amount of alcohol intake is there in combination with at least one metabolic dysfunction, metabolic factor, then we can call it MET ALD. So the wall between the and alcoholic fatty liver disease is now gone. Both can exist together, which is a reality. So coming to the MAP study, which actually mapped the across different Indian population, the prevalence of MASLD was 68.2%, and the prevalence of fibrosis was 33.7%. The north zone leading, followed by central zone and west zone, but east zone is also not far behind. And there are several metabolic factors like obesity tops the list, followed by type 2 diabetes, hypertension, high TG, which can cause this MASLD. Now, the pathogenesis, previously it was known as two-hit theory. Now it is a multiple hit theory where there is genetic susceptibility along with several environmental factors like metabolic dysfunction, gut microbiome composition, immune-mediated mechanisms, which actually parallelly runs and hits the liver, for which the healthy liver in 20 to 30% cases is converted to alcoholic fatty liver disease. 10 to 30% of that is converted to steatohepatitis, that is the inflammation with ballooning of hepatocytes. 10 to 20% of these is converted to cirrhosis, and 4 to 7% lands up into hepatocellular. But this is not the whole part of the scenario, because at the same time, MASLD can cause CVD and CKD with a risk of 84% prevalence of major adverse cardiovascular events, risk of peripheral arterial disease 75%, followed by ischemic stroke, cardiac arrest incidence, CKD prevalence, risk of MI, presence of CAD, AF, and bradyarrhythmias, and it is actually 2 times more prone to ESRD with vast CKD processes. So how to diagnose? First, how to suspect? If there is any liver steatosis in the routine ultrasound, if there is unexplained elevation of liver enzymes, if there is type 2 diabetes or 2 or more metabolic risk factors, if there is a history of MASLD cirrhosis in first degree relative, then we usually go for certain laboratory studies. The first is, of course, LFT, P-time, INR, serology, CBC with platelets for some indices, fasting sugar, A1C, lipid profile, and we have to exclude certain diseases which can cause liver fat. Like if there is clinical clue, we may do ferritin to exclude hemochromatosis. To exclude Wilson's disease, we should do ceruloplasmin, TTG for malabsorption, and alpha-1 antitrypsin deficiency if there is any family history. And autoimmune hepatitis profile is must before stamping a patient to MASLD, because this is very common in middle-aged females. So there are certain important indices, of which the most common is the FIB-4 index, which is the quickest way to evaluate liver fibrosis. And we can calculate it by a very simple formula. Age, AST, platelet, and ALT can serve the purpose. And the app is available on web portals. So there are other indices also like APRI, NFS, ELF, Fibrospect. But as it is easily available and it has high positive and negative predictive value, low cost, and recommended by major guidelines, and it is directly proportional to CV events, all-cause mortality, and liver events, it is usually the commonest index which is used for diagnosing liver fibrosis. So the cutoff is, if it is less than 1.3, it rules out fibrosis. If it is more than 2.67, it is high probability of fibrosis, and there is definitely an intermediate zone. So whenever the FIB-4 index is suggestive, we go for a non-invasive method, that is vibration control transient elastography, or VCT, which we popularly know as FibroScan. On my right hand panel, there is liver fat estimation, that is a controlled attenuation parameter, which is expressed in a decibel per meter. For non-obese, it is less than equal to 237 is absence of steatosis, and more than equal to 293 is grade 3 steatosis. In between, there are grade 1 and grade 2. And in the left-hand panel, there is the liver stiffness measurement, which is expressed as kilopascal. If it is less than equal to 7, there is absence of fibrosis. 7 to 10, 10 to 13, and 13 to 16 are the mild, moderate, severe, and more than equal to 16 is cirrhosis. So whenever we diagnose by non-invasive method, first of all, we have to emphasize the patient for lifestyle modification. It's already been discussed. But to reduce liver fat, at least 5% weight reduction is needed, and to reverse the steatohepatitis and liver fibrosis, 7 to 10% weight reduction is needed, which is very tough in real life. And the patient should be encouraged for the diet, which is already described by Indira Maisnam Madam, my previous speaker, and also for exercise, aerobic exercise every day, and 2 to 3 times per week, resistance exercise, and definitely whether it is alcoholic and non-alcoholic, patient should be asked for abstinence from alcohol. Now, when the non-pharmacological therapy fails, we start the pharmacotherapy in MASLD. Already few points have been discussed. We are very lucky that we have now the few FDA approved drugs. First of all is resmetirom, which is the thyroid hormone receptor beta agonist, approved as an antifibrotic drug in MASLD in 2024, which is unfortunately not available in Indian market. The second drug, which has been recently approved, already mentioned by Dr. Monam, that it is injected semaglutide, a GLP-1 receptor agonist, which is available here, and we will soon get it in Indian Railways, in Eastern Railway also. And the third drug is saroglitazar, a PPAR alpha-gamma dual agonist, which is approved by Drug Control General of India in 2025. Previously, it was approved for only diabetic dyslipidemia. There are a few off-label drugs like pioglitazone injections, liraglutide, tirzepatide, SGLT2 inhibitors, and vitamin E, which can actually used, but it is not FDA approved. So resmetirom, this is a New England Journal Medicine study which showed that there is significant reduction of steatohepatitis as well as liver fibrosis and LDL cholesterol with this semaglutide, with this resmetirom, 80 to 100 milligram, and there is 30% reduction in hepatic fat with mild GI side effects and 16 to 90% reduction of FT4. Second drug is semaglutide, already discussed in a study, Essence study group study. It has been shown that 534 received SEMA 2.5 milligram once a week with 266 placebo, with a duration of 72 weeks, which showed significant reduction of steatohepatitis and also liver fibrosis. And it is a very safe drug, as already discussed. In an eight-year trial, it has already shown that it decreases the all-cause mortality, cardiovascular event, advanced liver disease, new ascites, new encephalopathy, and new varices in a significant amount. So last is the saroglitazar. Several Indian studies are there which showed that there is a significant improvement of the NAFLD activity score in 52 weeks trial, and also there is a significant reduction in the LSM and CAP in a 96 weeks trial. And when it is extended to 144, the mean KPA has decreased significantly from 22 to 10 KPA. And so ultimately the expert association consensus statement approved it, and DCGI approved it in MASLD. It is available in our railway setup also. So future directions, few existing drugs are there which are already have completed phase 2 trial, like dapagliflozin and tirzepatide, and maybe in future there will be also a very good drug for MASLD. There are some drugs in pipeline like obeticholic acid, fascinoid X receptor agonist, pan-PPAR agonist, certain FGF analogs, which may or may not come out as a very good drug or a bad drug in future. We don't know till now. So back to the case, we calculated the FIB-4 index. It is around 3.5. USG abdomen showed grade 2 steatosis. Fibroscan showed significant grade 2 steatosis, as well as liver thickness, mild. So plan of treatment is that reinforce lifestyle modification, replace glimepiride, which the patient has already passed 8 years. So replace it with injection semaglutide if the patient can afford. And if it is not affordable or available, then start at least SGLT2 inhibitors with saroglitazar along with metformin, and of course to optimize lipid lowering agent and antihypertensive drugs. So to conclude, we can remember a mnemonic: M for MASLD, that is metabolic dysfunction associated steatotic liver disease, which is redefined now. A for association of at least one cardiometabolic risk factors. S for screening or diagnostic tests like USG, FIB-4 index, and VCT are strongly recommended. L for lifestyle modification and weight reduction at the first line management. And D for drugs like semaglutide and resmetirom are FDA approved, and saroglitazar is DCGI approved. So in near future might be a situation comes when we will really conquer the MASLD related cirrhosis, and which was a dream once upon a time. Thank you very much.
Thank you, Dr. Mishra, for your very, very excellent, extensive discussion. But one thing, now I will give it to Dr. A.K. Basu to speak a few words.
So thank you all the speakers. They have done adequate justice for the topic's assignment. So I have some little bit comments now about Dr. Indira. She has extensively discussed and shed light on the obesity. One thing that if we go by the BMI, then perhaps we'll lose a very chunk of Indian, because Indians are basically thin fat, and YY syndrome is very much known to everybody almost here. So abdominal obesity, which is a surrogate marker of insulin resistance, and rightly told by Mounam, the Indian subset, this is more prevalent. So waist-hip ratio and the fat measurement, etc., are there to exclude the abdominal obesity. And secondly, as Indira has told, all this management from the primordial level. So one thing is very important, that the maternal malnutrition during pregnancy is to be taken care of, is to be strongly addressed. Because if it is not addressed properly, then the Lord Burkert hypothesis, the thrifty phenotypes and defective programming of pancreas and all the organ, not only pancreas, all the organ. So down the line, these small birth weight babies will develop and will be obese one, maybe generalized, surely abdominal. So that is a very important aspect which we should hammer. That is the maternal malnutrition during pregnancy should be strongly addressed. And now about the monum, the semaglutide have some ophthalmological complication also. So I think in this era of medical legal problems, particularly in US, this has resulted in hue and cry. So ophthalmological AION should be kept in the back of mind. And regarding Shormista, all these drugs are in the non-cirrhotic muscle. Is there any weight out in the cirrhotic muscle? Your
No.
take.
No, basically, they are actually decreasing the fibrosis stage, at least one stage, but not when fully developed cirrhosis has happened. But there are researches going on.
Yeah.
There are some drugs which are showing the future directions. I have named this. Might be in future we have some drugs, but till now we have anti-fibrotic agent, but not anti-cirrhotic agent.
Yeah. And one bottom line is that we should never recommend the ursodeoxycholic acid, all these things, because they are adding
I
to the
didn't
cost.
include that also.
Yeah. So
I omitted.
this is some general practitioner they recommend. So this practice should be abandoned. And also vitamin E has not that much role.
Vitamin E in non-diabetic population is
Some
used.
role, but
Some histological
no.
changes has been seen, but now we have much more better drugs. So
Yeah.
practically the use of vitamin E is decreasing.
And have you used the resmetirom?
It is
You
not
know,
available, sir.
in the not.
No.
So over to the audience for one or two questions, because all these speakers adequately shed light on the topics. So if there is no question, I profusely thank all the speakers and conclude the session and the organizers for giving
Thank
me
you,
and
sir. Thank you, sir,
this
for
opportunity.
conducting it so nicely. So I'll request our chairpersons and the speakers to kindly go to the memento section. Oh, sure, sure. I think we can have that photo there. There's a thing in front of you. You can stand and have the memento and photo as well. So we will move on to the next session, that is OD versus BD, inhaler therapy in asthma and COPD. The speaker is Dr. Shelly Shamim. Dr. Shelly Shamim. Pen drive দেওয়া আছে? Dr. Shelly Shamim is not here. So we move on to the next session, that is Beat the VAP. And our speaker is Dr. Choyan Bhattacharya. And our chairpersons are Dr. B.C. Rai and Dr. Ashok Shaha. So we skip one session. If Dr. Shelly Shamim comes, then we will insert that. Right now, we are going to have Bit the VAP, Dr. Choyan Bhattacharya, the speaker, and the chairperson, Dr. B.C. Rai and Dr. Ashok Shah. I'll ask the chairpersons and the speaker to come to the stage.
Good afternoon. The topic is VAP or VA. So ventilator-associated pneumonia is a very common phenomenon in the critical care, and no other than Dr. Choyan Bhattacharya of our hospital. He's looking after the intensive care, and not only that, he's a very good trainer. He has trained up the PGTs so well that they are equally competent not as equal to him, but nearly as equal to other PGTs. So hopefully he'll do justice to the topic and take you down to the very important topic associated with pneumonia in the ICU setup. Over to Dr. Chayan Bhattacharya for his deliberation.
Respected chairpersons and August gathering. Today we know that's a joke. No baby will be delivered without cesarean section and no person will die without ventilation. So everybody, every person on this earth in his lifetime, once or twice will receive the ventilator. Ventilator is life-saving nowadays. Once upon a time, we think that ventilation means that is the end of the era, end of the life. But ventilation is not the end. Sometimes it is life-saving for some people in some situations. But ventilation has its complication. And once upon a time, it was dreadedly think as the ventilator-associated pneumonias. But it is the single entity. No, it is not the single entity. It is only the tip of the iceberg because it is the amalgamation of atelectasis, ARDS, pneumothorax, sepsis, pulmonary edema, pulmonary emboli. For that reason, till 2013 and 2010 and 2013, we think that the VAP is the marker of ICU credentials. That means how ICU is good or how the trainers or how the treatment is, how best the treatment is available in that ICU depends upon the incidence of the ventilator-associated pneumonia. But later on, it has been found that ventilator-associated pneumonia definition has multiple flaws, and it will not do justice to actual events in happening to the ventilated patient. So the new nomenclature has come, that is ventilator-associated events. Because this VAP diagnosis depends upon various subjective matters like radiological opacities, fever, abnormal white blood cell count, impaired oxygenation, and increased pulmonary secretions. But this cavitation, this temperature, increased respiratory secretions, and other thing, everything can have. Oh, sorry. It is transmission related or associated descent, TAE, not VAE. So the current definition of the ventilator associated pneumonia is not strong enough because it is objective, it lacks specificity and certainty, it is complicated, differentiate among other clinical conditions. So the VAE concept came by the CDC in the year 2008 onwards. So VAP is an approach for the surveillance to see how effectively infection control and the ventilatory strategy is maintained in an ICU. So what is the VAP? The VAP is defined as a pneumonia occurring more than 48 hours of endotracheal intubation or tracheostomy and initiation of the mechanical ventilation. Where the VAE, that is a ventilator-associated pneumonia, is defined as it is a period of worsened respiratory status on the ventilator. So every time the patient is getting ventilated and every day, every hour or timely, we are monitoring the patient regarding their ventilatory requirement. And any worsening is defined as a ventilator-associated condition. And these ventilator-associated conditions are divided into three groups. One is the ventilator-associated condition itself. One is the infection-related ventilator-associated complication and possible ventilator-associated pneumonia. So VAP is not negated, but VAP is included at the last. These incidents or these conditions can happen in ventilator in 3 steps. So first is the criteria of ventilator-associated condition. The patient is worsening, patient is not coming up. We cannot wean the patient from the ventilator. So what is happening? How to diagnose that? That sustained increase in the ventilatory setting. That is either of the following of the 2 days. Now after 2 days, we are saying that FiO2 requirement has increased by 20% or PEEP increase is more than 3 centimeters than the previous day or the previous hours. When it is happening, we are saying that the patient is having some ventilator associated condition. We cannot ventilate the patient properly, or the patient's lung condition is not ready to be ventilated properly. Next comes the infection related ventilator associated complication. Here, again, the SARS criteria is coming up, that temperature more than 38 degrees centigrade, WBC count more than 12,000 or less than 4,000, that is a low count sepsis. A new antimicrobial treatment has started and continued for more than 4 days. That is, we need to escalate the antibiotic therapy. So it is infection-related ventilator-associated condition. And now, lastly, is the possible ventilator-associated pneumonia. Here, the positive culture report is present, where in the last criteria, we did not require the culture, whether it is infection. Next, non-legionella antigen or the viral PCR is present, and the histopathological evidence of the pneumonia. So here, IVAC, that VVAP, there is a pneumonia VAP that is confirmedly diagnosed. So how serious VAE is, that initially VAP needs to take time to diagnose, and before diagnosis of VAP, the patient is already worsened and patient is unable to come up from the ventilator. We are introducing much and more and more antibiotics, which are more costly. So when the patient is having ventilator associated condition, there is a high chance that the patient will require much more ICU stay, much more antibiotics, and patient's mortality and morbidity will increase. So pathogenesis, if you see, so pathogenesis, if we don't know the pathogenesis, we cannot prevent the VAE. Pathogenesis include colonization of the aerodigestive tract, aspiration of the contaminated secretion, endotracheal tube biofilm formation, compromised host defense, direct inoculation, inhalation of the bacteria, and the hematogenous spread. So risk factor for the VAE is either patient-related or the procedure-related. Here, one thing I must say, that some of the patient-related condition we cannot predict or we cannot change. But like age, we cannot change. Extremes of ages are more prone, especially your immunocompromised state. Patient having the high aspiration risk, as in the dysphagia, we need to put the nasogastric tube or the supine position. Compromised defense, as in endotracheal intubation, will prevent or it will jeopardize the airway defense. Tracheostomized patient, impaired mucociliary clearance. On healthcare associated exposure like prolonged mechanical ventilation, frequent reintubation and suctioning, inadequate airway hygiene, medication and intervention like sedation, neuromuscular blocker, antibiotic use, like that. But procedure-related complication or the risk factors, these are very much preventable, like intubation, multiple intubation in patients, airway suctioning, open suctioning, bronchoscopy, enteral feeding, medication administration through the airway tract, blood transfusion, improper antibiotic therapy, improper hand hygiene, improper oral hygiene. These factors are much more important in a ventilated patient because these are preventable. And this is very cost effective. This does not require doesn't require to know the rocket science because it is easily available and amenable. So now go to the main part, that is the prevention. Prevention costs less than the treatment. So if you prevent from the very beginning, that will save so much of money. First is hand hygiene. Hand hygiene, hand hygiene is the cure for more than 99% of the disease, and it will prevent the cross contamination in between the patient. Next is the head end elevation, at least by 30 to 40 degree. It will prevent the aspiration, micro aspiration, and it will prevent the aspiration pneumonia. Next is the oral hygiene, because oral patient intubated state on ventilator, oral mucosa is the harbinger for the various infections. So oral maintenance of the oral hygiene is very important in prevention of the VAE. Ventilator weaning, we must go for a protocolized weaning, like everyday daily sedation interruption or the sedation holiday, assessment of the readiness to extubate using various markers, and spontaneous breathing trial every day. Another is the avoid condensation on the tubing. Every time we can see that the tubes are loaded with the water. So everyday drainage in a sterile way is the way to prevent the ventilator associated condition. Cuff pressure documentation, because prolonged intubation with a high pressure cuff will prevent the tracheal blood flow, and there will be the tracheal necrosis, and there is a chance of infection. So every day we must check the cuff pressure at least twice. HME filter usage, every 72 hours, we must change our HME filter to prevent condensation. It is the most important, that is the endotracheal tube. This is the most important, that is the endotracheal tube with subglottic suction. Subglottic suction drainage. So
Please continue.
Huh?
Continue.
This type of tube has got a supraglottic suction port, and this suction port will drain secretions that will prevent the biofilm formation. And these tubes are not very costly, but these tubes are costlier than the normal endotracheal tube. But this escalation of the very small amount of the cost will prevent a higher cost of treatment of the VAE. So these are the few studies who have shown that the subglottic suction drainage system will prevent the VAE and prevent the cost of the therapy. Another is a closed suctioning. We do that suctioning in the intensive care unit with just detaching the tube and putting our suction catheter. But presence of the closed suctioning device will prevent the cross contamination. It will prevent the drop in the PEEP you have already produced inside the lung, and it will prevent the collapse. These are the few studies which have shown that the closed suctioning is better, far better than the open suctioning. So these are some preventive measure bundle: suctioning only when necessary, using suction catheter occluding less than half the lumen of the endotracheal tube, using the lowest possible suction pressure, inserting the catheter no further than carina, and suctioning no longer than 15 seconds. Limit the ventilatory circuit change. We only change the circuit when it is soiled and when it is malfunctioning. Every day or every 3 days changing the ventilatory circuit will not prevent the VAE, rather it will increase the chances of the ventilator associated events. Deep vein thrombosis prophylaxis. We must use the mechanical compression device or pharmacological low molecular heparin to risk of stress ulcer related mucosal damage. Sorry. So prevention is the need of the hour, because prevention is less costly than the treatment. Every time I'm telling, already 3 times I have told that ventilation associated event will increase the cost of the therapy and patient's mortality and morbidity. But prevention is the need of the hour, and prevention is very easy, as I have shown lastly. So prevention of the guideline recommendation as CDC, SAHA guideline, IDSA guideline, everyone is saying the active surveillance program with before mentioned all the procedures will prevent the VAE. So Indian Council of Medical Research in 2016 says the closed suction system and subglottic suctioning of the respiratory secretion is recommended. SSD, that is subglottic suction drainage, remains an intervention for the prevention of the ventilator-associated pneumonia and other VAEs. And same thing was echoed by CDC in 2014, and same is by the IDS and EPIC. So thank you for your patient hearing.
Thank you, Chayan. Exhaustive presentation, very good. And I think we should conclude this session.
Yeah.
So I'll request our chairpersons and speaker to go to the memento corner and have their mementos. Oh, acha. Our chairperson has something to say.
Thank you, Chayan, for delivering such an important thing in a very short period of time. I just point out one point that bronchoalveolar toileting plays an important part in this thing, in prevention of the events. And number 2, keeping the oral cavity clean and secretion free helps a lot. Thank you so much.
Thank you, Dada. Thank you.
So Dr. Shelly Shamim has come, I think. We are going to have his presentation. That is OD versus BD inhaler therapy in asthma and COPD. And our chairpersons are Dr. S.K. Rokchit and Dr. Porna Banerjee. I'll ask all the chairpersons and Yes, sir.
Today's topic, OD versus BD inhaler therapy in asthma and COPD. Today's speaker, Shailesh Samim, Associate Professor and Head of the Department, Calcutta National Medical College. Welcome.
Thank you. So today we'll have a small debate on this OD once daily versus twice daily inhaler therapy in asthma and COPD. I'll start quoting this paper published in 2023. Is once versus twice daily dosing better for adherence in asthma and COPD? Adherence, that is the main point, I think. And it clearly shows, yes, it is. Once daily users have significantly high median daily adherence compared to twice daily, and it was true not only for asthma, it's true for COPD also. The figures also says the same thing clearly. The blue one, once daily, higher adherence compared to the orange one, the twice daily regimen. So in the debate of OD versus BD, key difference is adherence. However, the choice also depends on specific medication that you want to use, type of disease, whether asthma or COPD, disease stability, severity, nocturnal symptom, and patient's need. So multiple factors are there. So we need to go little deeper in the matter. Asthma and COPD, they are not same disease, rather they are different. If you see the definition of asthma, there are symptoms like wheeze, shortness of breath, cough, and chest tightness, and they vary over time. That is important. Variable symptom in between period, they remain more or less normal. Whenever there is attack, sometimes they are having attacks. In contrast, in COPD, it is fixed airway obstruction. That's why we see a persistent exertional dyspnea, and the symptoms are not that variable. So persistent symptom with along with persistent progressive airflow limitation is the picture of COPD. So just a pictorial representation. This is a typical picture of COPD, elderly man having difficulty in walking, going upstairs, climbing first or second flight of stairs. Whereas in asthma, we see attacks. They have the people having sometimes attacks, coughing, sometimes they take inhalers, having with relief. So that's the picture of asthma. Asthma, if you see the pathophysiology, if the person is genetically susceptible, then if they are exposed to typical allergen or occupational sensitizer, they're having typical asthma-like inflammation, which is mainly eosinophilic rich, and that typical asthma-like inflammation leads to hyperreactivity of the airway. Airways becomes primed. Once the airway is primed, if it is exposed to trivial amount of triggers, trivial amount of stimuli, it can be a small amount of allergen, can be non-allergic triggers like air pollution, cold air, virus, any smoking, any other irritants, that leads to cascade of reaction, and mediators are released, and there is attacks of symptom, cough, wheeze, and shortness of breath. So that is asthma. Typical line or lineage of cells like T helper type 2 with eosinophil, neutrophil, mast cells is fine. Not only there is airway smooth muscle cells, hypertrophy, and bronchoconstriction, we find also lots of inflammation in the airways. There is leakage of the plasma, lots of edema there, and the mucosal damage is there. Lots of hypertrophy of the mucous cells, goblet cells with mucus plug inside. Like this. In asthma, ultimately, you will have this bronchoconstriction, not only because of the there is a lot of inflammation, a lot of mucus, thick mucus inside. So if you just use bronchodilator, it can only work on muscles, but what about those inflammations, edema, those mucus hypersecretion will not be covered up. So that's why only bronchodilator will not give a much symptomatic relief. So we need anti-inflammatory agent, and inhaled corticosteroid is seen to be best anti-inflammatory agent in asthma-like inflammation, where we find a significant improvement. So in asthma, ICS is main therapy. In COPD, things are a bit different. Again, there is airway obstruction, but the factors definitely there in the inside, the mucous capacity is still there. There is factors in the wall, some amount of remodeling, some amount of inflammation, fibrosis are there, but the main factor of obstruction actually lie outside the wall. Our airways are dynamic structure. It's a normal airway. During inspiration, it slightly dilates. During exhalation, it constricts. Now, this is because of positive intrathoracic pressure during exhalation, and this effect actually gets augmented in COPD. In normal airway, this constrictive effect of positive intrapleural pressure are balanced by the elastic recoils of the attachment of the alveoli, normal alveoli. But that is lost in COPD. That's why these airways gets collapsed during exhalation. So what happens is that if the patient takes a breath in COPD, during exhalation, as there is collapse or near collapse of the airway, the exhalation becomes suboptimal. Not all full air is exhaled. So some amount of air stacking is there. So this happens. Take a breath, exhale incompletely, again breathe, exhale incompletely, again breathe. Now you'll see how difficult it is to take another breath in. So that is COPD, the airway hyperinflation, the dynamic hyperinflation. And because of this dynamic hyperinflation, the diaphragm is flat, and the ventilation or breathing becomes difficult. Now, if you use bronchodilators, small amount of dilatation of the airway actually can relieve this air stacking or hyperinflation. The lung gets deflated, and that's why we find a lot of symptomatic relief. They have increased exercise tolerance. So that's why in COPD, bronchodilators are main therapy. Now, these are the medicines, long list you use in asthma. Mainly we use inhaled corticosteroid or combination. In combination, you find ICS LABA, usually the salmeterol fluticasone or formoterol budesonide, commonly we use. Other than that, we also have the vilanterol fluticasone, maybe triple therapy like vilanterol fluticasone and glycopyrronium or indacaterol glycopyrronium mometasone. All are actually approved in India for use in asthma. However, among them, you'll find these three are in OD formulations. Others are the commonly used formoterol budesonide are we use in BD formulations. Now, the guideline also, if you follow the GINA, you find that to treat asthma, you have to follow either track 1 or track 2, the step care approach. And GINA says the track 1, that pathway is the preferred pathway, and track 2 is alternative pathway. If you cannot use track 1, then only try track 2. So track 1 is preferred pathway. So little deeper in that matter. In track 1, we classify the patients as mild form. Mild form means either symptom very minimum, twice a month or like that, or maybe more than that, but less than daily symptom. No nocturnal symptom, PFT is normal. That is milder form of asthma. In milder form of asthma, we put the patient in either step 1 or step 2. Whereas in moderate form of asthma, where we have daily symptoms or maybe nocturnal symptom, may have sometimes lung function may be compromised. So in these conditions, we consider them as moderate and put them in step 3 or step 4. If the patient is not controlled even in step 3, step 4 treatment, then we consider it as in step 5. That's different. Now, in treatment algorithm, in track 1, we find that in milder form of asthma, only use SOS ICS formoterol. The science is if you use maintenance ICS in this group of patients, they are bound to default because in between period they remain well. So that's why use ICS formoterol, which has quicker action, and that's why they'll have not only relief, as you are using ICS, that will take care of the inflammation also, and they will have little exacerbation. Exacerbation rates will be reduced. So that's why this is the current protocol. Whereas in step 3, step 4, we use maintenance ICS formoterol, either low dose or maybe medium dose. But if you use ICS formoterol as a maintenance therapy, always use the same ICS formoterol as a reliever. Whenever there what you are doing is that you are giving extra ICS, and that will during the exacerbation, and that will prevent severe exacerbation. That's science. Whereas the alternative pathway, so the track one, which is the preferred pathway, there is no role of, I would say, OD therapy. Always formoterol based means BD therapy or maybe SOS. But if you follow the alternative pathway, they will find that in step 3, step 4, there is option of use of other ICS LAVA. That there you can use for the vilanterol or fluticasone propionate, but that is alternative pathway. But always ensure that if you are using alternative pathway, ensure that patients are compliant. They will use it regularly. In COPD medicine, we find again several agents, but I will concentrate on these. The triple therapy commonly used, the vilanterol fluticasone glycopyrronium or vilanterol fluticasone omeclidinium, or maybe formoterol budesonide glycopyrronium, or maybe indagraterol glycopyrronium. These are the LAVA-LAMA combination, or maybe ICS LAVA like formoterol budesonide or
Sir,
salmeterol.
please sum up.
Just 1 or 2. So among them, you will find this triple therapy, vilanterol fluticasone glycopyrronium, vilanterol fluticasone omeclidinium. They have they can be used in a OD dose. Again, indagraterol glycopyrronium or vilanterol glycopyrronium, they have OD dosing. If you see the guideline also, usually we divide the patients in exacerbators, means E, or less exacerbator, where according to symptom, we classified them as either A or B, means less symptom and more symptom. If the patients are exacerbators, we use either triple therapy or LAVA-LAMA. Even in group B, where the high symptom are there, low risk of exacerbation, we use LAVA-LAMA combinations. So if you follow the guideline, definitely you can use, either you'll use a LAVA-LAMA or LAVA-LAMA ICS, and that can be used in OD formulations. And I told OD formulations has the advantage that it has, patients are more compliant to that. So I'll conclude 1 or 2 studies just. There's a real world study where you can find that assessment of COPD related outcomes in patients initiating once daily or twice daily ICS LAVA. And it was found that patients initiating once daily fluticasone furoate vilanterol were more adherent and were associated lower risk of subsequent COPD related exacerbation compared to twice daily regimens. Again, if you find the triple therapy in real world studies and from the Medicare data, the same thing, the twice daily regimen means budesonide glycopyrrolate formoterol have 9% higher incidence of first moderate severe COPD exacerbation compared to once daily regimen. So that's why another molecule we have, the vilanterol glycopyrronium or fluticasone combination. Vilanterol is short acting, based rapid onset of action and have a longer duration of action. The same is true for glycopyrronium. They have more selectivity to M3 compared to M2, means cardiac side effect will be less. If we combine them, we can have OD dosing. And Indian trials, RCTs are there on this. The vilanterol glycopyrronium fluticasone furoate were compared with the BD dosing, that is glycopyrrolate, formoterol, and budesonide, and in 12 weeks it is found that they are comparable. The BD dosing and OD are comparable in FEV1, symptoms, and exacerbation rates. So that is RCT, but in real world, we'll have advantage of adherence. So with 25% increase in adherence, we know 10% reduction in severe exacerbation will be there. So that's why I'll conclude. So if you see the history of inhalation therapy, 1780, there was only much inhalers, means only the mist were used. Then portable nebula, some kind of hookah like thing came in 1850. Then first inhaler came in 1950. Usually used the salbutamol. Then dual drug inhaler came in 1990, means ICS LAVA. And then in 2000 to 2010, we started using the triple therapy in multiple inhalers, means ICS LAVA in one inhaler, another tiotropium. And then came 2010 to 2024, where you started using single inhaler triple therapy, maybe formoterol and glycopyrronium combinations. And now it's era of using OD once daily triple therapy. So that's, thank you.
Thank you, Dr. Shamim. We are running short of time, so we have to conclude now. I'll request our chairpersons and the speaker to go to the memento area and collect their mementos. We'll rapidly move on to the next session, which is lung transplant, who and when. The speaker is Dr. Ongida Dasgupta and chairpersons Dr. Chumki Dotto and Dr. Moshumi Mojumdar. I'll ask the chairpersons and Ongida to come to the dais.
So this is a filler session. Unfortunately, Dr. Soumitra Sinha Roy could not attend because his mother is in critical care services back in Chennai. So he had to leave. And I'm just filling in for him. Lung transplantation, who and when? So let me start off by asking the audience, what are your thoughts? Which is the most important organ in your body? Brain, okay? So why do you think is the brain? Ki brain transplant hoy na? See, God has created us and has put certain organs in a cage. So what are the organs which are in a cage which is bounded by our bones? This is one, right? The lungs, the heart, and a little bit of the pelvic organs. But what about the GI system? Nothing. So the most important organ system in the body are those which are covered by bony skeleton. And that is why lung transplant is being discussed, because it's a very important organ. But the difference from the GI person or the GI transplant, liver transplant for that matter, is because of this cover. না আমি তো কিছু দিইনি, এটা কেন হচ্ছে এরকম? কি এটা তো অন্য। হুম হুম হ্যাঁ
অঙ্গিরা দাশগুপ্ত নামে অঙ্গিরা দাশগুপ্ত অঙ্গিরা দাশগুপ্ত।
So they can't find the file, which is pirated from my previous speaker. So this is really funny because the slides are not coming up and I'm talking in a foreign language about a difficult topic which I have no clue of what it really means. So lung transplant can be done, like we all know. It's bilateral lung transplantation, unilateral lung transplantation. Yeah, now we've got it. Or a heart-lung transplantation. So read that as lung transplantation, who and when, Dr. Soumitra Sinha Roy. That's not Ongira. Okay, so what are the challenges? The reason why we do a lung transplant is that when the patient has been treated with the maximum amount of medications that is possible in a chronic lung disease. So remember the word chronic lung disease. That's when we think of a lung transplantation. So this is just telling you that a chronic lung disease can be COPD, could be an ILD, could be pulmonary arterial hypertension, and possibly cystic fibrosis. So what is this? What does this X-ray show? So we had an excellent radiology, pulmonology crosstalk. So, but the radiologists have vanished. Nobody's there. Would anybody want to take a chance at what this is? Trachea shifted to right side. Yeah. Fibrosed lung, okay. hyperinflated left side. Okay, so can I ask you why you think that it's hyperinflated on the left side? It's compensating for the fibrosis on the other side? Okay. But let me tell you, there are certain things, just if you look at it very, very carefully, there are opacities in the left side which are linear in nature. Yeah. So some form of a procedure has been done there. So when it's a lung transplant talk and when we are discussing an X-ray like this, it means that the lung transplant has happened on the left side, and the right side just tells you what the lung used to look like when it was not transplanted. So this is all residual knowledge. Okay, so let's see. A 32-year-old nurse had COPD. As expected, bilateral lung infection was there recurrently, and the patient often went into a septic shock and would again come back with treatment. GRU, Pseudomonas, and MRSA did not respond that much to the colistin, meropenem, vanco, moxie. Choyan has already told us about all of this. The patient was on a ventilator and ECMO. Moribund patient, there was no improvement. So what would you do next? Again, because it's a lung transplant talk, the answer's got to be lung transplant. But the points that we need to note here is that the patient required ECMO to survive, right? So you cannot go on giving a patient ECMO day in and day out. ECMO is only one of the procedures that can be done as a bridging procedure between the patient's disease and lung transplant if planned. Other than that, it's practically not much use. So we consider lung transplantation when there is an end-stage lung disease in a chronic lung disease background. So these are the two words we have learned now. It's a end-stage lung disease, and it has to be a chronic progressive lung disease. And what are these? COPD, IPF, chronic hypersensitive pneumonitis, bronchiectasis, autoimmune diseases like sarcoidosis, CTD, ILD means connective tissue disorder associated ILD, cystic fibrosis, or GPA. So ultimately, when these end-stage diseases lead to a type 1 or a type 2 respiratory failure, needing supplementary home oxygen therapy and or no CPAP therapy, these are the patients whom we have to evaluate and start evaluating early so that we can progress for lung transplantation in the centers that can be used for such a surgery. So what are the types? Bilateral, unilateral heart lung. So I'm not discussing these in much details, not that I know very much about them. So if we move into a typical COPD patient, much like the one that we saw before, we should be prepared to refer the patient to the correct person in the correct time. So time is important in transplantation subjects in any organ, be it liver, be it cardiac, be it lung, anything, kidneys. Okay, so what is the time of referral? The patient has a Bode index of 5 to 6. And those who are pulmonologists would know that a Bode index consists of a breathing difficulty, oxygen, BMI, and eosinophils. So if the index is between 5 to 6, we need to consider a referral. If the PaCO2 is more than 50, we need to consider a referral along with a PaO2 of less than 60, which means that the patient has a type 2 failure, and if the FEV1 is less than 25%. So that's the time when we would consider referral to the transplant unit for an assessment. The transplant unit is going to do what after this? They are going to list down the name of the people who would require or who should be considered for a lung transplant. So board index again, more than 7, FEV1 between 15 to 20, 3 or more severe exacerbations, 1 severe exacerbation with acute hypercapnic respiratory failure, moderate to severe pulmonary hypertension. So all these conditions that we are seeing now here in a patient and considering referral and time of listing are things which are irreversible. So you cannot reverse all these things. They are there to stay once it occurs. So similar to COPD, another indication of a chronic lung disease which is progressive in nature, required transplantation would be interstitial lung disease. UIP or a fibrosing NSIP pattern, regardless of the lung function, is what the indication for ILD, primary indication for transplantation in an ILD is. Abnormal lung function, that is a low DLC or low FVC, any dyspnea or functional limitation attributable to lung disease, any oxygen requirement, even if it's only on exertion, and for inflammatory ILDs, which fail to improve even with the guideline-based treatment at the very severe stage. When would you list an ILD patient for a transplant? Decline is more than 10% in FVC during 6 months of follow-up, decline in more than 15% of DLC on 6-monthly follow-up. The 6-minute walk test is something which is very important, and we fail sometimes to give it an adequate importance in our workup. But it's really important that we do an exercise test, because there are many patients whom we see with a normal PaO2 or a normal saturation at rest, and we never bother to take a exercise measurement, which should always be done in patients with advanced lung disease like COPD, ILD. So recipient selection, there is a whole list. I'm not going through the list. Instead, I will show you this picture. So which side of the lung has been transplanted? A lot of whispering, but no one's answering. It's simple. Okay, so when you say right, does it mean my right or is it your right? X-ray right. So the X-ray also has a right and a left. So how many rights? How many lefts? Okay. So this is a left-sided lung transplant. Why? Because you see it's clean. The lung looks clean. Whereas on the right side, you find there are white things on it, right? So whichever is black is good for us because we don't know what it is most of the time. And the one which is white is also important to us whether we know what it is or not. So I think complications of respiratory failure are important. So if it's an early respiratory failure, causes of a respiratory failure after transplant, if it's an early, these are the reasons. And if it's more than 3 months, infections and BOS means bronchiolitis obliterans. And this is a timeline which bacteria, which fungus, which virus is going to invade you and give trouble to you. So you can just read it up sometimes. And thank you.
Thank you, Dr. Ongira. It's a very nice presentation. Till 10 to 15 years back also, you could not think of lung transplantation so easily. But nowadays, due to its advancement in medical profession, lung transplant has become very, more or less a routine transplant. And in India, in Delhi, in Max Hospital, they are the pioneer of the lung transplantation. And 5-year survival rate is common in after lung transplantation. With these few words, may I close this session?
Thank you. I'll request the chairpersons to please go to the memento area. And so we rapidly move on to a very interesting session and that is robotics in uro-oncology, past, present, and future. Past, present, future, but we have only 8 minutes. Fine, no problem. Dr. Gaurav Agarwal, the speaker, and Dr. Shubir Kanjilal and Dr. Shoykot Sengupta will be your chairpersons. May I request the speaker and the chairpersons to please come.
Robotic uro-oncology, past, present, and future. This is a very interesting subject and very pertinent subject of nowadays. And Dr. Gaurav Agarwal is a consultant robotic uro-oncosurgeon of HCG Cancer Center. We'll talk about it now.
Good afternoon, everyone, and thank you so much for this opportunity. While I'm getting the slides, I just say that if you go around the city anywhere, all you see nowadays are hoardings of robotics, as if robotics is the panacea. It's one size fits all. So the robot can cure and take out everything from the body. Now, is that actually 100% true? I've got 8 minutes, like Sir said, for the past, present, and future, and I hope to finish it and sum it up in this time in my field. Now, I look after the waterworks of your body. When they go wrong or they go haywire, that's when I come into the picture. So the past, just if we talk in terms of surgery, the past, everything was open surgery. Then come to the present, open surgery was taken over by laparoscopic surgery where indicated, and now a bit of robotics. And future, is the future only robotics? Let's find out. So what is this word robot? We all hear it, robot. What's it? It's actually a Czech word, and it was used in one of the plays. That's Rossum's Universal Robots in 1920. That's the origin of this word robot. So all it says is that it's actually your slave, it's not your master. As time evolves, from 1999, that's when the first bot came in, the robots have evolved. And you can see the picture on the right side, right of the screen. That's how the robots used to look in 99, and that's in 2017. And we all know they've further improved. The initial company, Da Vinci, which was for Intuitive Surgicals USA, has brought out thinner, better, more equipped robots. But so has Make in India now. So now there's a plethora of robots to choose from. The point is, where is it beneficial? Now, first and foremost, we all think it's the robot that does the surgery, not the medicos, the non-medicos. Well, that's not true. It's the surgeon who does the surgery with the help of the robot. And yes, there are a lot of challenges. For a surgeon, his hands are very important. There is no tactile sensation. Your vision is your judgment. And whatever finger movements you're doing are translated verbatim by the robot inside the patient. There's a big, big learning curve. Look at the installations in India, more than 100 and more than 5+ in West Bengal itself. Now, everything has advantages and disadvantages. Yes? So what are the main advantages? There's less trauma, smaller cuts, less scarring, less infection, less pain, less blood loss, blah, blah. Are there any disadvantages? I've enlisted them. There's an initial capital investment. There's maintenance. There's training the surgeon. You can't just sit today and start operating tomorrow. It takes time. It's a long time. So in the waterworks, what are the main surgical procedures where a robot can actually be used to the benefit of the patient? Prostate, absolutely. Bladders and kidneys. And the others are, as you can see, enlisted. Emergency and unscheduled surgery I've put in red. You have to fall back to your open procedures. So let's see it one by one. If I'm talking of prostates, you can see over time the number of robotic surgeries have increased, laparoscopic and open are almost done, not being done nowadays. Why? Because a robotic surgery helps you get these kind of specimen. A classical prostate, the first one on the left, you have a prostate, a patient who has undergone a TURP. That's a small channel created in your passage to improve your flow. And you get a fibrotic prostate like that. This is not possible either with open or laparoscopic surgery. What about the kidneys? Kidney sparing partial nephrectomies, radical nephrectomies, and nephrouretrectomies. Again, you can see the numbers are going up. Look at what this RCT tells us. Partial nephrectomy, we all know, is less morbid, lesser hospital stay complications. But in terms of functional outcomes, a robotic partial nephrectomy has lower incidence of chronic renal insufficiency as compared to open and laparoscopy. So this is definitely an advantage for the patient. And these are the kind of specimen you'll get. That's a full radical nephrectomy, that's a partial nephrectomy, and almost akin, it's an adrenal, which is located, the right adrenalectomy, located in the narrow space between your liver, the renal vessels, kidney, and your main vessels, the IVC and the aorta. Again, a nephrouretrectomy, a huge tumor in the ureter, 8 to 10 centimeter tumor in the ureter, entire specimen en bloc. The third procedure is cystectomies. It's not 100% mandatory to do it by a robot. There's still no difference in outcomes. So advantages, I've told you. So just to let you know, ammunition. Now, this is how the surgeon sits on the console. I'll just give you a few clips to see if you can understand what's actually happening. Now, here is where the robot is getting docked. The robot is, instruments are being introduced into the patient's body. This is our team at work. You can see that though the surgeon is sitting on one side and operating, the white thing in the center is the robot, and you have the entire team looking on the vision card, having a look at what we are actually doing. That's a surgeon sitting there on the console. It's like a video game, but it's dealing with real human life. This is the kind of vision that we get. This is the ligation of the DVC. We all pelvic surgeons know this is the bane of a pelvic surgeon. And at the end of it, that's how it looks like. Small cuts, 8 millimeter cuts, to reach deep down to your pelvis and get your specimen out. The robot's done its job, it's going back. So from the waterworks, I'd say one symptom or one red flag which you need to remember is red. That's blood in urine. Now you'll all ask me, all this costs. How can we afford it in India? It's very expensive. You have to navigate these healthcare costs wisely. So we need proper data. I've given you WHO data. I'll give you data for this as well. Just look at Health Organization says. India is one of the most affordable countries in healthcare. And robotic surgeons in India rank among the top 10 in the world because of high volumes, high skill sets. I'm not saying this, WHO is. So it's now become an accepted practice, yes, robotics, and the increased cost is offset by reduced hospital stay and complications. And I'm no one to tell you what's morality and what's conformity. We all know this. So just before I sum up, I'd say the strengths of a robot are in radical prostatectomy and partial nephrectomy for pelvic surgeries. The weakness is in case of surgical emergencies and surgical crisis. Opportunities are Make in India robots, and threats, many juniors or many junior surgeons are not concentrating on their basic open surgical skills. So that's our team. And yes, robots are redefining the future of healthcare. Thank you all so much for a very patient listening.
Thank you, Dr. Agarwal. You have discussed the very practical points of robots. It's very useful, but we have to consider the other problems. But definitely, robotic surgery is the in thing, no doubt about it.
Sure, ma'am, if they allow.
My question is, how often, currently, because now you have got a long span of learning curve, how often robotics gets converted? Because lab we know, more or less, robotics, nobody actually tells us what is happening.
Yes, that's a very pertinent question, ma'am. So, initially in your learning curve, you will have a mentor with you. You'll not be doing it independently. So, there'll be a mentor who will be sitting beside you, having a look at step by step where you're going. So, the procedure might take you longer time. The mentor takes over as and when you have trouble in between. So, conversions are less. And as you go up, it's a step by step approach, the same we did for laparoscopy and open. So, as you go up the learning curve, the number of conversions go on reducing because you'll have a mentor for the initial few cases when you start off. Ma'am, again, the conversion depends on multiple factors. So it would also depend on certain factors intraoperatively. It would also depend upon if, for example, if I need to make a big incision to get the specimen out, there's no point doing a robotic for that patient. The choice, the patient selection becomes most important.
Thank you, sir, for your very important deliberation. And I'll request our chairpersons and speaker to kindly move on to the memento dais for receiving the mementos. Thank you. So, we are coming to the last session of today's program. And I'll have to run through because of paucity of time. And it's actually a session, multidisciplinary approach to cancer, a mixed bag. And the chairpersons, Dr. Madhuchanda Kaur, a very senior B.R. Singh Hospital. So I'll take the privilege of requesting the speakers also to come on. Dr. Dipankar Roy, Professor and Head of the Department of GI Surgery, Medical College Hospitals, Kolkata. Dr. Shomok Dash is an Associate Professor, School of Digestive and Liver Disease, IPG MER, Kolkata. Dr. Sanjay Sen, HVS Oncosurgery, B.R. Singh Hospital, and associated with Peerless, Apollo Gleneagles, ESI Hospital, Shialda. And again, lastly, Dr. Gopal Achari, a very senior neurosurgeon of the city who's had over 26 years of experience in neurosurgery, associated with Park Clinic, Tata Medical Center, Kolkata, and working with us in B.R. Singh half years. The mic to our chairpersons for a brief introduction. Let me just tell you one thing. This is an interactive session which is not meant for a very specialty or super specialty audience. It's meant for a generalist audience. And I've selected a specific cancer from each specialty. We'll go into the details based on a case. We'll give you the history, the workup, and the follow-up and protocolized management will be discussed by the panelists. So I'll request the audience to kindly come forward so that they can interact. So I'll request our chairperson, Dr. Madhuchanda Kaur, to say a few words at the beginning.
Okay, let us not waste any time. Good afternoon, everybody. We are now on for a very interesting session, which is very pertinent in our day-to-day practice, because as you all know, globally, out of every 9 people in the community, one will develop cancer. So since the incidence is so high, all of us should have a working knowledge of how to approach a patient with particular malignancy. And before the panelists take up this session, one thing I would like to highlight for all the doctors present here, please devote some time in the workup of these patients, because cancer is a very heterogeneous disease. And what we have now, so for this personalized approach, our workup should be thorough so that the perfect treatment is given to the perfect patient. With these few words, let us go on to the session properly.
So we begin with Dr. Shomok Dash, and here is a case for him. A 72 years old female patient presented with a history of pain in the upper abdomen. ঠিক আছে, এটাই এসে গেছে। With a history of pain in upper abdomen since 2 months, dyspepsia, significant weight loss, and loss of appetite. And as you can see, a USG is showing a hyperechoic foci with posterior acoustic shadow, an intraluminal mass, and diffuse wall thickening of the gallbladder. These are the CCT abdomen pictures. And then let us move on. Let me ask about a brief talk on the diagnosis, on the workup of these patients.
It is a 72-year-old female patient presented with a gallstone, and on investigation we have seen there is a gallstone and also a interluminal mass. It looks like an interluminal mass. It's not extending beyond the gallbladder, but we have to confirm it with a axial imaging like triphasic CT abdomen, also CT chest at the same time, and that tumor markers like CA19-9 and CA we have to do.
So that is in short a very concise view on the workup of this patient. And after laboratory studies and imaging studies, we'll go on directly to the management.
Do you think CA19-9 and CA will be high in this patient?
Don't think so.
Yes,
but
because they will not give any answer.
Yes, but usually we do, if these are high, we can follow these patients after the treatment very easily. Yes, usually don't, but if does.
There is only one point to be noted. Very often we have seen that on pathological review of a gallbladder removed for a benign disease, there has been an incidental detection of a gallbladder carcinoma. So,
yes, that regarding that incidental finding of a gallbladder CA, mostly these are not incidental. Actually, the thing is that when we do a cholecystectomy, most of the time, after cholecystectomy, gallbladder to pathology, and then it comes like it's malignancy. But usually we should cut open the gallbladder on the back table after the completion of the surgery, and we have to see any mucosal irregularity was there or not. And if there is there, we should do a frozen if it is available. Otherwise, so after this workup, we can say it is incidental. So true incidental gallbladder malignancy should be very low, but whatever we get, usually they are missed gallbladder carcinoma, mostly missed gallbladder carcinoma.
So that is an important point to be taken. And then we come on directly to the management. Management is multimodal in nature, but I would like to stick to gallbladder cancers which are early, because there are basically two groups, early gallbladder GB cancers and advanced GB cancers. So in the case of early GB cancers, which are limited to the gallbladder with no infiltration of the liver or the serosa, surgery will be the treatment of choice. Now, what surgery would you prefer, or what is the preferred?
The surgery usually we do a radical cholecystectomy. So, which is radical depending on the stage of the gallbladder tumor. See, it may be a simple cholecystectomy for a T1A tumor like the incidental gallbladder CA, but usually we have to do a extended cholecystectomy where the part of liver is to be removed along with the portal lymph node and all lymphatics, we have to bear the porta. Sometimes we have to remove the bile duct as well, particularly when the cystic duct margin is positive, or the tumor is near the gallbladder neck, or it's a suspected what is called good biological the papillary variety tumor, then we have to remove the cystic bile duct as well. And for the ease of lymphadenectomy, sometimes we have to remove the bile duct.
But very often in our Indian population, the profile of cases which we get are in the very advanced stage or in a fairly advanced stage, where the scope of surgery is rather. So what surgery would you prefer? Or do we have to go in for palliative measures, say in advanced gallbladder disease?
If the present case is operable and we can do a PET CT to see there is no distant mets, then we can think of surgery, a radical surgery, like what I have said already. But if it is not, if it is infiltrating the liver or some other organ, even we can think of surgery. But if it is little more invasive, we can think of a pre-op chemotherapy and then go for surgery if it is then still resectable.
Can I chip in? Very often patient comes with cholecystectomy. They are not willing to go for immediate extensive cholecystectomy. So we practically do some bridge therapy, like you said. We can do some.
Yes, we always bridge therapy till the
So we
patient
do
is
that,
not
not ready for surgery, maybe motivated after 2-3 months, after 2-3 cycles of chemotherapy. Is that the standard, or it is our improvisation?
That I'm not that much sure, but the thing is that we are working in a government hospital. There we cannot put the patient, if the patient comes and go for surgery in the next week. So it is always better for us to give chemotherapy.
Even in private, they are not willing to go for another surgery immediately. So we do this.
So that was a brief overview on gallbladder cancer, its presentation, surgery, and other options available. And now, lastly, is there any role of a preoperative biopsy or tissue diagnosis?
Preoperative biopsy or tissue diagnosis may be done for the cases which are not operable for giving chemotherapy, or which may be operable but it's locally invasive. We want to give some preoperative chemotherapy, we have to go for a biopsy. Otherwise, it's not recommended.
And what is the money? As per the protocol, the prognosis after surgery for early GB cancers is rather good.
Yes.
But for advanced cancers, the prognosis is less than 20% survival over 5 years. So you are agreeing with that?
Yes.
So thank you, Dr. Shomok Das. We will be moving on to the next case, and our panelist expert, Dr. Dipankar Roy, a 62-year-old gentleman presented with subacute intestinal obstruction, diffuse pain abdomen with significant loss of weight, with occasional painless bleeding per annum and loss of appetite. And the colonoscopy shows a large ulcer with elevated margin in the rectosigmoid junction, which bleeds on touch. So we are suspecting a rectosigmoid growth, rectosigmoid carcinoma. And would you highlight us on the diagnostic tools?
You have already listed it, but digital rectal examination will not be there. It's only available in the lower rectal cancer. First is CT, CECT, chest, abdomen, pelvis. That is mandatory. Of course, you need a colonoscopy or sigmoidoscopy to have a tissue diagnosis. But having said that, if the patient presents with frank obstruction, then you may have to omit that. Only other thing is, many of the times, the patient may not be able to have a full colonoscopy. Full colon may not be visible if it is like this kind of patient. But I'm a bit surprised, because if it is an ulcerative lesion, then the patient should not present with subacute intestinal obstruction. they may present sometimes, we get cases because of extra intestinal adhesion, bending like that, patients is having incomplete bowel obstruction time to time. Otherwise, it's not, it is usually the mass presents with incomplete bowel obstruction. Nah, this ulcer only, yeah. PET CT, not routinely recommended for colon cancer staging, not routinely recommended. One of the interesting part of, interesting indication of PET CT is left colon cancer, you are suspecting for some reason there can be synchronous growth and the colonoscopy cannot be done completely for obstruction or something technical issues, then PET CT can give you an idea of any synchronous lesion. Then your management plan will be different. One of the indication for PET CT. Otherwise, not routinely not.
So your recommendations regarding diagnosis and workup have been well taken, because we have to focus on those investigations only which will give you maximum information. And it's not no point in over investigating a patient.
Yes.
So we come on to the management directly. Well, the management will depend on the location, site, and stage. And as an experienced gastrointestinal surgeon with a wide experience in laparoscopic surgery, I would like you to highlight some points about the surgical management.
This patient is having rectosigmoid growth, incomplete bowel obstruction. The only option is to do, unless in the CT there is a severe metastatic disease, then the surgery with curative intent should be the first line of treatment. Theoretically, obstruction can be relieved with stenting, but my so far experience with stenting, relieving obstruction and the staging is not very good. That they don't give much of relief in this kind of patient, particularly rectosigmoid growth. So upfront surgery, if there is no metastatic disease in the CT scan, upfront surgery. Technical issues, laparoscopy. Yes, incomplete bowel obstruction can be taken laparoscopy, but only it be more careful, because the proximal colon cannot be prepared properly and there will be more distended and edematous. Distended is more important to me is edematous. It's difficult to handle rather than on other thing. So it can be, and it will be laparoscopic anterior, whatever, laparoscopic or open, it will be anterior resection. Rectosigmoid growth, you need to take the upper rectum, and inferior mesenteric usually I try to ligate below the left colic. So all the lymph node clearance in the central lymph node, like inferior mesenteric artery, and it will be anterior resection.
Now, one point about anterior resection. What is the minimum, as a surgeon, minimum margin of resection according to the latest techniques, distal and proximal? 1 point.
5 to 7 centimeter. Theoretically, we have been taught at least 10 centimeter, but with more of Japanese experience, they are very fond of identifying the feeding vessel versus we don't have that kind of expertise. But 5 to 7 should be all right. Okay. Safe. But I tell you one thing, this is, I always say, but this is actually, no, it depends on after you need to have oncological clearance on the vessels. That is then depending on the vascularity, how much colon is vascular in the proximal, you may have to take in more after ligating IMA.
Yes. Okay. That will be on this on-table decision.
Yes. Yes.
And lastly, in the other perspective, many of our Indian patients in the Indian population with rectosigmoid growths in a very advanced stage, locally advanced growths with obstruction and extensive abdominal mets. So in that perspective or in that setting, what will be the surgery which you can offer to this patient?
Only diversion ileostomy initially, then of course chemotherapy.
And then yes.
We have a radiotherapy specialist, Shumon. Just a bit on the radiation aspect in early rectosigmoid. Just 1 or 2 lines, because this is becoming a reality. Is there any mic here? audience, because you said it is interactive, so there should be a mic there.
Radiation, good afternoon, everyone. Radiation is typically indicated in the cases in early cancers where the cancer is limited into the rectum. And if the disease is in the sigmoid colon, then it is not anymore a fixed structure, and giving radiation is not very.
That is my question to Dipankar. You treat this more as a sigmoid or as a rectum? Because it's a dicey situation.
Yes, absolutely. And I am just
And let Dipankar respond. So you behave as a rectum or a sigmoid? কত সেন্টিমিটার ছিল না? How many centimeters?
না বলা ছিল না 10 সেন্টিমিটার ছিল 10
Cancer from the around which is more of a sigmoid colon cancer, and here there is very limited scope of giving neoadjuvant radiation for this patient. So we should go for so then we can actually the distal the proximal margin of the tumor, if it is more than 2 centimeter into the sigmoid colon, then we are not going to give radiation therapy. But in case sometimes if the structure is fixed around the colon, like some T4 tumors, then we can have some scope of neoadjuvant radiation. After that, we can really go for the total mesorectal excision or the paracolic excision for the tumor.
The site of the lesion is very important.
absolutely very important. And
Otherwise,
nowadays,
rectosigmoid is a dicey situation.
dicey, whether it behaves like colon or a rectal cancer, it's very
One thing in rectosigmoid junction tumors, it's difficult to say whether it is upper rectum or colon, but if it's upper rectum part and it is anterior, it is the peritoneal surface, we can consider it is at a colonic tumor. If it is posterior and involving the mesorectal side, we have to give radiotherapy.
it's not audible. No. Yes, agreed. But nowadays, I'm just thinking for last 2-3 months, probably haven't done it. Rectosigmoid growth is probably new OG junction dilemma among the GI surgeons, because all rectal cancer behave very well with NSCT, CTRT, even TNT, and now the talk is already there that rectal cancer is probably going out of the surgeons. So whether rectosigmoid behaves like colon cancer or a rectal cancer.
No. So we now next move on to Dr. Sanjay Sen. With a case, a 55-year-old gentleman presented with a painless nodular swelling over the right inner cheek of mouth for 15 days, which bleeds on touch. A suspected carcinoma of the buccal mucosa. So, Dr. Sen, what would you advise for a diagnostic workup?
We'll first go with the biopsy. And if the biopsy is positive, we'll go for the staging workup. And it looks operable. And if it comes out as cancer, which is going to come out as cancer, we're going to operate.
Now, is there any role of getting a PET?
No, it's localized. It's completely localized. When
Because
we take the neck-
sometimes we are over-investigating.
No, it's not indicated. No.
So we go on straight to the management, and because oral cancers is a very important cancer in in the Indian scenario, and I would like Dr. Sen to outline the management protocol.
See, if it is operable, you should go for the operation. You remove the disease. If flap is required, you do a flap reconstruction. Along with the local removal of the local disease, we have got to go for a neck dissection. And then when the final histopathology report comes, based on that, we will decide the kind of adjuvant treatment which is to be given. That's clear. Nowadays, actually, the size of the disease is not that important because the free flap concept has come in. So even with a very large disease, reconstruction can be done effectively by a good plastic surgeon. So size is not an issue anymore, size of the tumor, which was in earlier days because there was nothing to reconstruct other than the local flaps or the regional flaps. But if sometimes some surgeons I find decide if on basis of the size of the disease, a neoadjuvant treatment they sometimes prescribe to reduce the size of the disease, and then they go for the surgery.
I have a point to make to the audience, some of whom are not interested, maybe they are taking photographs at the end. So, but to all the audience who are receptive till now, for head and neck cancer, surgery is the best choice. So please don't demotivate the patient. আপনি আবার অপারেশন করবেন, থাক রেডিয়েশন দিন, এখন তো অনেক রেডিয়েশন হয়েছে, টোমোথেরাপি, অমুক থেরাপি. So don't do that. If you really want to give a cure, wherever possible, go for surgery. So that is the carry home message.
That was a very important point made by our chairperson. And now we go to locally advanced and advanced stage. What is the role of surgery, or do we need surgery and multimodal therapy?
So if it is operable with a good flap, we can take out big tumors. Simple. Because surgery is, as Madhuchandadi said, surgery would be the best option. But if it is not operable, if it's invading the other adjoining areas of the oral cavity, like it is going posterior to the oropharynx, and it is suppose it's fixed tumor, hard tumor cannot be, even the vessels are involved, we will go for a neoadjuvant treatment. It depends on combination of the radiological finding and the surgeon's clinical findings.
And so we come to the end of that particular session. And lastly, the brain, which should have got top priority, we come to it last. And here is a patient profile, a 52-year-old male with a complaints of persistent headache for 3 months, progressive right-sided weakness, occasional vomiting, with no diabetes, hypertension, or CNS pathology. These images have come earlier. These are MRI images of a left frontal glioma. Clinical examination of the patient, there were no signs of raised ICP, and neurologically, there was a mild right hemiparesis, mild expressive aphasia, papilledema on fundus examination. So investigations revealed an MR brain with a left frontal lobe mass, irregular ring enhancement, necrosis, and perilesional edema. And a CT brain, which was done earlier, a hypodense lesion with surrounding edema. CT brain often doesn't give too much of information. So with this, the subject was offered a left frontal craniotomy and a near total excision of the tumor. And postoperatively, after the biopsy came, he was given an adjuvant therapy, radiotherapy, and temozolomide as per the Stoop protocol. Now, with this background, I'll request our expert panelist to give an overview of how exactly the workup can be done and what are the modalities to be followed.
I'll start off with can you hear me? Yeah. I'll start off with a small correction, but the latest CNS5 classification has dropped the term multiformic. So it is no longer GBM, it is GB. So if we have a diagnosis of imaging like Dr. Das shows, there is no other alternative but to have a surgery. You cannot avoid surgery in any situation unless the condition is very poor. If the condition is very poor, the alternative is no treatment. So if you are operating, if you are slide. We go back to the
Previous.
slide. Yes. So this is the goal of surgery. So we have a diagnosis of a glioma. So what should I do as a surgeon? As a surgeon, my role is to remove as much as possible without causing any damage. That is what is known as an oncofunctional boundary. To maintain the oncofunctional boundary, to resect as much as possible, improve the prognosis. So the next slide. So what is the rationale? If I do an aggressive surgery, I'm not only relieving the ICP, but also I'm providing a histology for the pathologist. And nowadays, the most of these tumors will require a molecular study.
most of these tumors would require a molecular study, and that increased the efficacy of the oncologist. Now, if you have a diagnosis like this, the question is whether it is a high-grade tumor, a low-grade tumor, or what is it? So, the one above is a T1 image. The one below on the left-hand side is a T2 image, and on the right-hand side is a FLAIR image. So the crux of the matter in case of glioma is you have to go back to biochemistry, to the Krebs cycle, where the enzyme called isocitrate dehydrogenase, it converted to alpha ketoglutarate by enzyme called isocitrate dehydrogenase. Now this enzyme normally produces alpha ketoglutarate, but because of mutation, this enzyme undergoes mutation at particular residues like arginine 132, 140, and 172 to produce 3 classes of IDH, 1, 2, 3. And because of this mutation, we produce an oncometabolite, which is known as alpha 2-hydroxyglutarate. Now, this 2-hydroxyglutarate is the bane of the situation, and it causes a huge amount of change and oncological change in the brain. We're not going into the details, but what we know that we have a class of gliomas which are now known as IDH mutated and one which are IDH wild. So when you have a histological, when you have an MRI picture like this, you see there's a mismatch. If there is any radiologist, he will help me out. There's a mismatch between the T2 on the left and the FLAIR on the right. This is known as a T2 mismatch sign, and this is a classic of an IDH mutated astrocytoma. The one on the right on the top is a peripheral ring enhancing lesion, and that's the classic of a higher grade IDH wild type of tumor. Now, the term glioblastoma is specifically reserved if the tumor is IDH wild. There is no mutation detected by the standard techniques. So this is another case where you can see a calcification, and there is no T2 mismatch. When there is no T2 mismatch, this is the case of an oligodendroglioma. So we have adult gliomas. We classically have a tumor of the astrocytic lineage. We have an oligodendroglioma, or we have the glioblastoma. The glioblastoma is now more molecularly defined. It can also be histologically defined by the presence of necrosis and proliferation. But the criteria of IDH wild has to be there for a diagnosis of GB. And the term, as I said, M has been dropped. It is no longer multiforme. So as a surgeon, when I have a patient like this, for me, it is important to preserve the preservation. So I use as many gadgets as possible, take the help of radiologists to find a tractography. I can do a functional MRI to find out the surrounding area of the tumor, how much function is there. So I can maximize the tumor removal. And I can use adjuncts like this, like a fluorescent contrast, or I can use a fluorescent contrast like this. And this, the center one, is the area which is taken the fluorescent dye is the one which is to be the tumor, and the surrounding blue area is to be left behind. So using these and also use of navigation of specific localization tumor helps us to maximize the safe removal. So once we have maximize the removal, sometimes when you go to the periphery, especially when you're dealing in eloquent area, we can use electrophysiology to define which area of the brain that you're dealing with. You can actually define the hand, the central cortex, the leg area, and the speech area. You can also keep the patient awake and operate if you're operating on a speech area. So using all these gadgets, the importance, as I will say, the idea is to have a maximal safe removal. That is, remove as much as possible and preserve the function. Once that is done, of course, we need to know what is methylation status. And once we know the IDH mutation, it is important for the prognosis of the patient, because if you have a simple calculation, if a patient is IDH wild and is unmethylated, the 1-year survival is 30%. If the patient is IDH mutated, unmethylated, that is IDH wild and methylated, the prognosis goes up to 67%. If there is IDH mutated plus methylated, the prognosis of 1-year survival goes to 87%. And if it is both IDH mutated and methylated, the prognosis jumps up to 90%. So that you can see how much these two factors have a prognosis in this patient and how much it helps the oncologist to define further treatment. So that, in short, I'm just giving you an overview of what we are dealing with. And I've spoken about isocitrate dehydrogenase and 2 and 3 types. and up to the pathologist to define which particular type of histology sequences they will use. For instance, most of the sequences if you use can be quite expensive. So if you have a diagnosis, like if you are doing an IDH1, can be diagnosed by ISC methods. But to find out IDH2 and IDH3, new gene sequencing or Sanger sequencing. So that is quite expensive. So we can tailor, any pathologist can actually tailor the amount of workup which can be done. And currently, the ISNO has come up with a new sort of a classification, which is an adjunct to the low socioeconomic group known as adapter. If you can use the adapter, by any pathologist is here, they can use the adapter and use the adapter to reduce the cost of these patients. So at the same time, when we are dealing with of these patients, even though the prognosis is poor, we as surgeons, it's important for us to maximize the resection and to keep the cost as low as possible, and for pathologists also to keep the cost as much as possible by using the standard sequences. Now, I cannot go into very details. It's a very high detailed techniques. I'm just able to give an overview. If you have any questions here, I'll be glad to take it.
So one question which I would like to ask, if formally, before the advent of advanced immunochemistry and genetic studies, we put all these patients or high-grade gliomas onto maximal safe resection, temozolomide and radiation therapy. We were not able to prognosticate the response to chemotherapy. Now, are we able to do that?
So actually, in the last decade, the methylation has come in a big way, and also the IDH mutation is there for quite some time. It's there for 2009 onwards, and now by CNS5 in 21 has been further defined. Prognostic was always there, but as I said, if you have methylation. Now, what is the importance of methylation? Now, methylation actually is a process of epigenetics. Now, if you're aware of epigenetics means that you have to change the phenotype without changing. So the expression of the tumor will change, so without changing gene structure. So how is that possible? So the process of methylation is that you add methyl groups to an enzyme and you cover up, like you cover a book. You cover an old book and make it a new one. So you change the enzyme by putting certain methylation levels. So once that happens, methylation covers up the enzyme, which is a methylguanine methyltransferase. Now, if you give temozolomide to these patients, methylguanine methyltransferase is destroyed. So in unmethylated patient, if you give temozolomide, this enzyme will destroy it. So if you look for methylation status, if you have methylation status, you know your drug will act. And if you have, as I said, if the patient has IDH wild, there is no IDH mutation. If the patient has no methylation, the prognosis is 30%. Now, if the patient is both mutated and has both methylation, the prognosis 1 year survival is 92%. So there's a big difference, and a prognostication can be done easily by this method, and the oncologist knows exactly what they're dealing with. And nowadays, we also have IDH1 and IDH2 mutant inhibitors like vorasidenib, and we also have histone blockers also, which has come in, like dorparidone, which has come in, dordaviprone has come in, and these are all more and more research are coming, and this is certainly helping us, and it has gone up a very exponential manner last few years.
So thank you, sir, for a wonderful deliberation. Your explanations were very lucid, and they were able to focus on a patient of a low grade as well as a high grade glioma, the recent advances, and the role of methylation. So due to paucity of time, we'll have to end this evening's panel discussion, and I will thank all the speakers here and our chairperson and Dr. Dipanjan Pradhan. Only one thing, একটা সূত্রে সবাইকে বাঁধতে হবে যে I have got one last thing to say, যে all our panelists here, they have been operating in BR Singh Hospital either on a case-to-case basis or on a regular basis for at least 3 to 4 years. And in spite of numerous constraints and infrastructural difficulties, they have been able to give the best of their skill in operating in this hospital. So a good round of applause for all of them and for joining this evening's panel discussion. I also thank Dr. Madhuchanda Kaur and Dr. Dipanjan Pradhan for their one hand. And lastly, before we finish, we will request all of them to come to the memento site for receiving mementos from our chairpersons.
And just one, please don't leave. Just one more announcement that I have to make. That we had a e-poster competition. Nobendu, are you here? I think the results are ready. If the results are ready, then we can announce it today. I cannot see any of the judges over here. So in that case, we will give the prizes tomorrow. Nobendu, Dipanjan. That to Nobendu আছে কি? Are all the participants of the e-poster here? Only one. I would have liked to finish off this thing with giving off the first, second, third medals. Ongida, did you get any news? They are still calculating. So why don't they come over here? No. Oh my God. Without announcing the result? Let them come, because otherwise all the participants are over here. I'll request all the judges of the e-poster to come over here. Dr. Anandodas Chaudhary, I think you better take your seat over the stage. Dr. Anandodas Chaudhary, Dr. Debashish Bandyopadhyay, Dr. B.N. Jha and Dr. Shomok Das. I'll request you to come over to the stage and give the first, second, third medals of the e-poster. I'll request all the judges, the four judges, Dr. Anandodas Chaudhary, Dr. Debashish Bandyopadhyay, Dr. B.N. Jha, Dr. Shomok Das, to please come to the stage and take your seat. And do you have the results? Nobendu, do you have the result with you? Please. Okay, while Nobendu takes 2 minutes, I'll ask Dr. Jha to say a few words regarding the standard of the e-posters that he found.
Thank you, sir, and all my respected friends. We have got the 27 papers today. Almost one papers added, 28 papers. All the papers was having. They have gone through the best of their efforts. Lot of needs, improvement was needed, but almost everyone was trying to give us the clinical presentation, particularly clinical case-based presentation. Some doctors, it was very difficult to judge us because most of them are having the same range of this. So it was a very nice to see at least 28 papers, and I would like to request to everyone to give a round of applause for all the participants. Winners, winning.
I'll
is not
request the
important.
participants to come forward. Please come forward.
So all postgraduate students, particularly 10 among the medicine department, 10 students from the pediatrics, and 2 surgery, 2 obs gynae, and other department ENTs and surgery. These are the excellent. Even some students have dared to present 2 papers. So it was nice to see, because purpose of the conferences are to ignite the young brains. That is our main purpose for that. Ladies and gentlemen, result is not important. Participation is important. My co-judges, I would like to request to say a few words.
Hello. Everyone has presented very nice, but first there will be someone will be first, someone will be second, someone third. That doesn't matter. Everyone is doing good. Thank you.
So I'm going to announce the prizes. I'll first announce the third prize. The third prize goes to Dr. Mukul Kelkar, General Medicine, DNB PGT. Mukul is here? Mukul is not here. Any of his friends over here? No. Okay, fine. Sir will take. So the second prize goes to Dr. Nishant Dhiman, DNB Residence Medicine. Is he here? Nishant is also here. So I'll request Nobendu to collect the prize for him and give it to him. And the first prize goes to Muhammad Imroz. Is he here? Imroz is also not here. Okay, I'll take the prize for Imroz. Oh, Imroz is here. Imroz, you have got the first prize. Come and collect it. So we have come to the end of today's scientific session. Tomorrow we will again meet at 9 a.m. here, and the free paper session will be held at Manthan simultaneously. And today we are going to have the inauguration program at 6 in this hall, which will be followed by a cultural program and a gala dinner. All are invited for the inauguration program, cultural program, and the dinner with family.
হ্যালো মিড কাম করো তো মিড হ্যালো হ্যালো চেক চেক হ্যালো হ্যালো হ্যালো
दीजिए सर कोडियल चेक कर रहे हैं हेलो हाँ हाँ बोलिए अभी देरी होगा अभी अभी हाँ हाँ हेलो चेक हेलो हेलो टेस्टिंग टेस्टिंग हेलो हेलो चेक चेक हेलो 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 चेक चेक हेलो नीचे कर रहे हैं हेलो चेक चेक हेलो हेलो टेस्टिंग टेस्टिंग हेलो हेलो चेक हेलो हेलो चेक हेलो चेक हेलो 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 चेक हेलो 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 चेक हेलो हेलो ठीक है हाँ हेलो हेलो चेक चेक हेलो ठीक तो है
কোন ল্যাপটপ একটা পাশে এইটা তাহলে ল্যাপটপে চালিয়ে দিতে হবে পেন ড্রাইভ কেন লাগবে F আরে তাহলে আমি গানটা করবো কি করে ইমাইকে গান করবার দেখে লাগাবো কিন্তু এইটা একটাই প্রবলেম হচ্ছে এটা আমার 30% চার্জ হয়ে আছে চার্জার থাকলে আমি চার্জার আছে এটা কি দেব চার্জারটা চার্জার আছে চার্জারটা দিয়ে দিলে একটু আমার ফোনটা রিস্কি কেন এই যদি ফোন এসে যায় মাঝখানে তাহলে আমি এরোপ্লেন মোড করে দিতে পারবো হ্যাঁ ওটা এরোপ্লেন সেই সময়টার জন্য এমন না করলে সেই সময়টার জন্য নেট দিয়ে তো চলছে এইটা নেট দিয়ে চলছে না মানে ফোনটা তো চলছে নেট লাগবে না না এটা আগে লাগান আমি একটু প্র্যাকটিস করব টাইমারে রয়েছে এটাকে এখানে করবো এটা লাগাবো এর মধ্যে হ্যাঁ আপনি এটা দিন তো ওটা ছেড়ে দিন চলছে क्या चालू करे सर्वतः पाहि मां देवी महालक्ष्मी नमोऽस्तुते महालक्ष्मी नमस्तुभ्यं सुरेश्वरी हरिप्रिये नमस्तुभ्यं
नमो नित्यम् सरस्वत्यै नमो नमः वेदान्त विद्यास्थानेभ्य एव च।
2060 किसका गाड़ी है? थोड़ा सा बाहर में वो गाड़ी लगी है, जीएम साहब का पर आ रहे हैं, वो गाड़ी हटवाना है। आ गया।
Hello, hello.
Hello, 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 check, check, hello, 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 check, hello, check, hello, 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 check, check,
Hollow. Check. Hollow. Check. Check. Hollow. Check.
check, 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 check. Check, check. Check 1, 2, 3. Check, check. Check, check. Check 1, 2. Check, check. Mic testing check 1, 2. Mic testing check 1, 2, 3.
hello, 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 check, check, hello, check, check, hello.
Respected ladies and gentlemen, honorable dignitaries, delegates, esteemed guests, members of the Railway Medical Fraternity, print and electronic media, a very good evening to you all. With immense pleasure, myself, Dr. D.R. Dash, and Dr. Ongira Dashgupta, on behalf of IRHSA Eastern Railway, welcome you all to the inaugural ceremony of the 50th Annual Scientific Seminar and CME program being held at Dr. B.C. Roy Auditorium, Shealda. After an unprecedented pandemic in 2020, which put conferences and CME programs on hold, these events have made a comeback into the mainstream, with the present initiative being organized in the form of ER Medicon 2025. The program will now be formally inaugurated with a ceremonial lighting of the lamp, and may I now take the privilege of requesting Dr. Jagdish Chandra, Director General Railway Health Services, to kindly step forward for lighting the sacred lamp. At the same time, I request other dignitaries, General Manager Eastern Railway, Sri Milind Deoskar, Shami Sharvotamanando, Vice Chancellor, Ramakrishna Mission Vivekananda University, Dr. Ashish Basu, ex-principal Calcutta Medical College, PCMD Eastern Railway, Dr. B. Nataraj, Divisional Railway Manager Shealda, Sri Rajiv Saxena, Medical Director B.R. Singh, Dr. Guho, and Dr. S. Mukhopadhyay to join in the lighting ceremony. I will request and Madam Dr. Usha Chandra, AGM Eastern Railway, Sri S.P. Singh, President ERWWO Headquarters, Madam Seema Deoskar, Dr. Uma Nataraj, President ERWWO Shealda, Madam Nidhi Saxena, Dr. Shudeshna Lahiri, and Dr. Usha Singh to kindly come and join in the lighting ceremony. It is now time for calling of our respected delegates onto the dais. I now take the prerogative of calling upon our chief guest, Dr. Jagdish Chandra, Director General Railway Health Services, for taking his place on the dais, and he will be escorted by Dr. Kalpana Mondol, CMS Shealda. Our respected General Manager, President of the inaugural session, Sri Milind Deoskar, is kindly requested to come onto the stage, and he will be escorted by Dr. Reena Mukherjee. The esteemed President of the conference, Swami Sarvotamananda, you are requested to kindly come onto stage, and he will be accompanied by Dr. Joyita Banerjee. Dr. B. Nataraj, PCMD Eastern Railway, is requested to come on to the dais, and he will be accompanied by Dr. Mondira Banerjee. Divisional Railway Manager Sialda, Sri Rajiv Saxena, may kindly take his place on the stage, and he will be escorted by Dr. Joyashree Fauzdar. I'm sorry, by Dr. Choitali Patro. Medical Director, VR Singh Hospital, Dr. Debashish Guho, may kindly come onto the stage, and he will be accompanied by Dr. Joyashree Fauzdar. Dr. S. Mukhopadhyay, Secretary, IRHSA BR Singh, may kindly take her place on the dais, accompanied by Dr. Choitali Patro. Resplendent with tradition, this evening's program will begin with an inaugural song sung by Dr. Ongira Dasgupta, Saraswati Vandana, as an invocation to the Almighty.
पद्मालये शुभे विद्यास्थानेभ्य एव च सरस्वती महाभागी वेदे कमललोचने विश्वरूपे विशालाख्ये विद्या देहि सरस्वती ॐ शान्ति शान्ति शान्ति
Thank you, Dr. Dasgupta, for a very wonderful rendition. Keeping in line with the traditional Indian practice of welcoming our guests, let me take the privilege of presenting our dignitaries with floral sticks mementos, and ceremonial utturios. Dr. Kalpana Mondol is requested to come onto stage for presenting a floral stick and mementos to Dr. Jagdish Chandra, Director General Railway Health Services and chief guest of this function. Dr. Reena Mukherjee is invited to come onto the dais for presenting a floral stick and mementos to Sri Milind Deoskar, General Manager, Eastern Railway. Shami Sarvotamanando, Vice Chancellor, Ramakrishna Mission, Vivekananda University, will be presented mementos and honored by Dr. Joyita Bandyopadhyay. Principal Chief Medical Director, Eastern Railway, Dr. B. Nataraj, will be presented mementos and honored by Dr. Mondira Banerjee. Dr. Choitali Patro is requested to come onto stage for presenting a floral stick and mementos to Sri Rajiv Saxena, Divisional Railway Manager, Sealdah. I now take the pleasure of inviting Dr. Joyashree Fauzdar for presenting Dr. Debashish Guho, Medical Director BR Singh, with a floral stick and mementos. And Dr. Joyita Bandyopadhyay is requested to present a floral stick and mementos to Dr. Shormishtha Mukhopadhyay, Secretary, IRHSA, Shialdah. After handing over of mementos to our dignitaries on the dais, it is time to felicitate our dignitaries seated below. Dr. Mandira Banerjee is requested to present a floral stick and a memento to Sri S.P. Singh, Additional General Manager, Eastern Railway. Dr. Kalpana Mondal will be presenting a floral stick to Dr. Usha Chandra. Dr. Reena Mukherjee will be presenting a floral stick to Madam Seema Deoskar, President, ERWWO Headquarters. Dr. Joyashree Fauzdar is requested to present a stick, floral stick to Dr. Uma Nataraj. Dr. Joyita Bandyopadhyay will be presenting a floral stick to Dr. Sudeshna Lahiri. Dr. Kalpana Mondal is again requested to present a floral stick to President ERWWO Shialdah, Mrs. Nidhi Saxena. And Dr. Choitali Patro is again requested to present a floral stick to Mr. Vishal Kapoor, DRM Howrah. We acknowledge and mention the special presence of PCMD madams and sirs of other zonal railways and welcome them to this evening's program. Face and voice become a monotony after some time, and so I break off now and hand over the microphone to Dr. Ongida Dasgupta, who will be continuing with the proceedings.
Good evening. After the initial inauguration and presentation ceremony, it's time for a formal welcome to all our guests. dignitaries and participants, and the best person to welcome them is none other than our MD BR Singh, Dr. Debashish Guho, and President of IRH SA. Sir, could you please step forward and welcome the August?
Good evening. It is my proud privilege to extend a very warm welcome to all the dignitaries and delegates of the 50th Annual Scientific Conference and CME program organized by Indian Railway Health Service Association, BR Singh Hospital, Eastern Railway, Shialda, on 1st and 2nd November 2025 in this beautiful auditorium. I welcome Dr. Jagdish Chandra, Sir, Honorable Director General Railway Health Service Railway Board, to have accepted our request to be the chief guest of the conference. I welcome our Honorable and dynamic General Manager, Shri Milind Deoskar, Sir, to have given his kind consent to be the President of the inaugural ceremony. I welcome Swami Sarvottomanando, Vice Chancellor, Ramakrishna Vivekananda University, to have consented to be the President of the conference. I welcome Srimati Shima Deoskar, President ERWWO, to grace the occasion as our guest of honor. I welcome Shri Shailendra Pratap Singh, AGM, Eastern Railway, all PHODs, all PCMDs and PCMOs, Shri Rajiv Saxena Sir, DRM Shialda, to the inaugural session. The theme of the scientific seminar and CME program is Comprehensive Patient Care Where Disciplines Meet, which truly reflects the spirit of modern healthcare, one that recognizes the power of collaboration among various disciplines to deliver holistic and patient-centered care. True healing arises when science, compassion, and teamwork converge for the well-being of every individual. Each discipline contributes a unique perspective, and together they form the foundation of effective and compassionate healthcare delivery. Now, let me take the opportunity to reveal facts about our BR Singh Hospital. BR Singh Hospital has the highest best strength among hospitals of Indian Railways, the best strength being 525. OPD attendance is more than 1500 per day. Daily indoor admission is around 50 per day. We can proudly say that the first CT scan machine was installed in BR Singh Hospital away back in the year 2015. Today, the first in-house MRI machine, which is state-of-the-art 3 Tesla MRI, has been inaugurated by our respected DGRHS sir and our respected GM sir. Cath lab, installed only second after Perambur Railway Hospital, has already performed more than 12,000 cardiac interventions, 1,800 CTVS surgeries, 6,500 pacemaker implants, and more than 600 special procedures like EP study, IVS, RFA, ROTA, etc. Our newly established 6-bedded neuro ICU and stroke unit is functioning, doing emergency procedures like thrombolysis. All hospital beds are connected with central oxygen pipeline system. We have 13 KL LMO storage plant. There is facility of triage in our casualty. We have a facility of 24/7 hemodialysis and in-house nephrology unit. Senior IRHS doctors are available 24/7 in all the major specialties in addition to DNB trainees. We can say that this facility is not even available in all private hospitals where senior doctors are physically present 24/7 in the hospital. I'm sure that this CME will help in updating the knowledge of the delegates and give the participants a unique opportunity to exchange ideas and scientific thoughts. The delegates will get the opportunity to learn the newer modalities of treatment in modern medicine. I, as organizing chairperson of the conference, wish all the delegates and distinguished guests, particularly those who have come from outside, a very beautiful and memorable stay in Kolkata, the city of joy. I wish the conference a grand success. Jai Hind. Namaskar.
Thank you, sir, for your words of welcome. B.R. Singh Hospital, Eastern Railway, Shialda, is the zonal hospital of Eastern Railway under the aegis of Shialda Division, and it will be very appropriate to hear Sri Rajiv Saxena, DRM Shialda. I request Sri Saxena to kindly step forward and say a few words on the occasion. Sir, please.
Good evening. All the dignitaries on the dais, DG RHS sir, General Manager Eastern Railway, and Vice Chancellor of the University, and other dignitaries on the dais, CMD, and of the dais also, AGM and PHODs from Eastern Railway. I have nothing to say in this occasion because this is mostly a technical conference, but from the user's perspective, we can say because in Sialda division, we have around 23,000 employees, a large workforce, which is dependent on the services given by B.R. Singh Hospital. And we have just seen the inauguration of blood separation unit also. So the requirement of blood is expressed by the hospital. So we will be organizing more and more number of blood donation camps on the regular intervals, and referral units have been set up in different primary healthcare units. So some of the units are actually working, but in some of the units, some work is required to be done, and whatever help is required, and we will request B.R. Singh Hospital to provide all the necessary assistance to these units so that our employees get benefited from this. And whatever else requirement are there, we are there, and hospitals from electrical side, from engineering side, we will be providing, and whatever input from our employees is there, we will be providing to hospital. And I wish this conference to be a great success. Thank you all.
Thank you, sir, for your speech. Dr. Basappa Natarajan, PCMD, Eastern Railway, and Principal Mentor, as well as Chief Patron of IRHSA, Eastern Railway, who has recently taken over the reins of the medical department, is the principal inspiration behind this conference. He is requested to kindly step forward and address this august audience. Sir, Dr. Nataraj, please.
Good evening. Respected DGRHS, Dr. Jagdish Chandra, General Manager Shri Milind Dioskar sir, Belur Mat Guruji Swami Sarvottam Anandaji, DRM sir Shri Rajiv Saxena, Medical Director Dr. Debashish Guha, and Secretary Dr. Sharmista, all PHODs, AGM, DRMs, and other distinguished guests, and all medical fraternity. I feel privileged and honored to welcome you to this 50th annual conference organized by BRSH academic team. I am thankful to DGRHS and General Manager, including DRM Sialda, for their blessings in this regard. As you all know, medical conference is a necessity and it is not option. To update knowledge, explore latest advances, and share challenges and experiences, and most important, to earn credit points, which is essential for continuation of medical registration in Medical Council. I am happy to announce you that West Bengal Medical Council has granted 7.5 credit hours for this conference. The theme of this conference is comprehensive patient care where disciplines meet. It's a well-chosen topic to meet the demand of the day. India shares 20% of world's disease burden, of which NCD is 60%, which poses challenges in the management, and we are literally chasing these untreatable diseases involving multiple specialties. Moving on to the broader perspective, Eastern Railway is also committed to preventive and promotive health of railway beneficiaries by implementing various national health programs, and one such being conducting medical camps for the railway beneficiaries in the remote areas. In the year 2024-25, we have conducted 3,069 health camps, and it is astonishing to note that we have detected 9,748 hypertensives and 6,594 diabetics. So this is the glimpse of the growing burden of the diseases. You should be aware that national public health expenditure is less than 2% of GDP, which is well below the target of 2.5% of GDP. Hence, a substantial increase in the health budget allocation is crucial to boost infrastructure and also to adopt newer technologies for optimal healthcare for the railway beneficiaries. Achieving universal health is a shared mission. It is a collective partnership and responsibility where every department's synergy and cooperation is needed for optimal healthcare. We have our own weaknesses and strength in Eastern Railway, and we have huge challenges, which we can overcome with the cooperation of DGRHs and General Manager and other PHODs. We have huge potential for growth in the medical department. MD and his team have worked relentlessly since few months to make this conference a success. I congratulate them and all the faculties and delegates for this contribution for the success of this conference. It's a proud moment today as a new in-house 3 Tesla MRI machine installation has been inaugurated by our DGRHs and GM, sir. I hope this conference has benefited all the delegates in updating their knowledge. Tomorrow, one more day is left. Many diverse topics have been lined up, and one of the speaker is Dr. Mitra Basu Chilla. He is a functional medicine specialist who has been invited from Mumbai, and he is going to talk on a subject which is an eye-opener for the modern medicine doctors. So in the end, I thank you one and all, and have a wonderful evening. Thank you.
Amongst us, immensely respected, learned personality, Shami Sarbotamananda, Vice Chancellor of Ramakrishna Mission Vivekananda University, Belur. A man with various facades who blends education, science, culture, and spirituality in his sphere of working. With such a rich background, I am extremely privileged to invite him to kindly present his words of wisdom and enlighten this evening's audience. Sir, please.
नमः श्री यतिराजाय विवेकानंद सूरये सच्चित सुखद स्वरूपाय स्वामी ने तापहारिणे। डॉक्टर चंद्र, डॉक्टर देवस्कर, डॉक्टर नटराज, Okay. Dr. Saxena, Dr. Guha, and Dr. Mukhopadhyay. I will say only a few words because as I can understand, this is a very technical session and my background is not medicine. My background is engineer, but I can presume that here, when you are talking about uh, where the disciplines meet, it is all the disciplines, not just across medicine, but other disciplines like engineering also. Because in our my background is computer science, so we know that we have a lot of projects coming where we do this imaging analysis, which might be, in fact, which is very helpful for the medical practitioners. In fact, modern day artificial intelligence has also become very popular. So I think that I can talk about this where disciplines meet in the in the patient care issue from the perspective of someone who is not a medical practitioner. I am also a kidney transplant patient, so I have got enough experience of being a patient in a hospital. So what I think about this patient care from the perspective of a patient, what we need is from the doctors is this emotional approach. What we miss in Indian scenario is that our doctors, actually that is true that our doctors do not have many time. In fact, just now when I was coming to institute, I was told that the doctors were really, they have so many patients per day to see that they don't have enough time to spend per patient. That is fine. Even patients do need, they know this, that the doctors do not have enough time. But what the patient expect the doctors is this emotional approach. The what was talked about is about the they want that the doctors, they should talk politely, talk nicely, and they should feel sincerity. So that is enough, because we don't want that the doctors should spend more time. We know that doctors don't have any time. They have to look at the patient. This is one aspect. Second aspect is really in a country like India, the problem is not just the doctors and hospitals. This apathy, it is everywhere. It is even in the general populace also, there is apathy towards these patients. For example, I say that when ambulances come when the ambulances travel in the roads of, say, Calcutta, city like Calcutta, I see that people do not give way. So why is this? If we talk about patient care, the patients should be cared not just by doctors and medical practitioners. They should be cared by the general populace. They should be cared by the staff, and they should be cared by the other patients also. See, what happens is patient, I am a patient, for example. I think that my problems are bigger than other problems. So even there is a more serious patient before me, I will think that I should talk to the doctor first, and doctor should give me prescription first. So this whole attitude of our society, actually we are really worried, because I am especially worried about our society only, because I have not seen how the foreigners behave, but I see how Indians behave. So I can talk about Indians. I don't like it. Actually, no one will like it. So what is the problem with this? Our attitude is not good. It is a secondary aspect. And even this compassion, we should have compassion, etc. That is, I think that should come later on. But we should have attitude. We should have an attitude of legal practitioner. So it's not just a profession. It is a way of life. So you have a certain thought about how the world should be. You have a vision and mission of the world. So that is what makes a doctor. For example, in education, we don't look at it as a profession. Now, for example, I am a monk. So because a monk, I have got certain freedom to look at things from idealistic point of view. In fact, I also look at the medical profession not as a profession, but from as a saver of life. No, it is what it is. Actually, it is why you have got Hippocrates' oath also. And it is not just a profession where you provide a service to the society, provide a service to the patient, and then you take money from him, and both of you are happy. It's not just that. It is actually you are giving him life. And as Dr. Nataraj said it, it's very much necessary. It's a necessity of society. It's necessity of society. In fact, necessity for a nation and necessity for patients. But as I see it from the spiritual angle of, from the spiritual point of view, this science and education, they are not just nourisher of bodies, but they also nourish the souls. You have to look from the spiritual point of view. Then you can understand why we have to do it. See, in engineering, whenever we have to whenever we have to solve any issue, we ask 3 questions: what, why, and how. How is also important. It is the same thing for doctors. How is very important. We are not just theoretical people. We are not happy with just what and why. We are also to answer this how question. So, for example, patient care, you have to ask, what is that? Naturally, technical aspects are there, and you know more about it. I talk about this SQ and EQ aspect. SQ is social quotient, and EQ is emotional quotient aspect. From a patient's point of view, it is more of emotional quotient and your social quotient aspect, and also affordability and accessibility and quality. That is there because that is what a patient want, that accessibility, it should be accessible, affordable, which is again the medical services of modern day, they are not. They are not accessible, they are not affordable, and quality also, because so many patients come, many hospitals, the quality is not there. So what we want is accessibility, affordability, and quality, and few other things are there. But these are the main for the third world country like India. You will see that accessibility, affordability, and quality. These 3 things are very important. So even education also, we talk about this accessibility, affordability, and your quality. And these things are really important. So in our patient care also, we want this accessibility, affordability, and quality. Quality, you see, you may think that quality is an additional word, and not many people are are interested in quality. But you see that if a certain facility is available in Calcutta, why are people running to South India? Why are people running to Delhi for doing same operation? Because they think that in Delhi or in somewhere in Vellore or some other place, they are getting a better quality. So that is why I'm saying this, because life is involved. No? So people want the best service that is available, whatever their money can afford. So patient care has to do with, as far I understand, is accessibility, affordability, and quality. Accessibility, now you have got this door-to-door care. When I go to Delhi for my medical checkup, this I hear all the time this new buzzword, or maybe this is an old buzzword, and I only heard it just now, this door-to-door care. So the hospital will go to the patient, and naturally they want to have this package system where they think that it can be made affordable. But second question is what I am more interested, why we should do that. And everyone actually stumbles on this question. What we know, what is this patient care, but why we have to do it and how we have to do it. Though we talk about compassion, etc., but everyone has to answer this, because this is a very materialistic, these modern times are very materialistic times, and this all the time you hear about this capitalist viewpoint, and about this give and take. So I can only give as much as I can get it out from it. In fact, that is what people as professionalism. Professionalism is that I am given some money and I provide service, which I say that it's not only that much. So this why answer, everyone has to find the answer. Especially doctors. See, doctors, I consider it is a noble profession. In fact, first moment that you enter the college, so whenever there is a freshers welcome address, your seniors and your teachers, they will tell you that you are the cream la cream of the society, and this is a noble profession. Why it is noble profession? Because it saves life. That is more important. Why it is? Because life is very important. One of the 2 or 3 things. So we say that Anna and Dan and Jivan. Jivan Dan, Anna Dan, Gyan Dan. So Anna Dan is first, then Jivan Dan is second, and Gyana Dan is third. So of the 3 danas, 3 charities, it is actually one of the very important charities. I say, I will not take much time, but why we have certain angle of seeing, why these things have to be, why we have to be compassionate. Because according to spirituality, the basis is that we are one. There is underlying unity in this world. It's not that the patient and doctor and the society and everyone are separate parties. It is a one party. And everyone is connected as a whole, even though we may not understand it, even though we may not believe it. But if it is real, you can understand that things change. If a doctor helps patient, the doctor is as much helped as much as the patient is helped. Because there is underlying unity, the help provided to the patient comes back to the doctor. Maybe later in the later life or in the next life, because no question we believe in future lives. So we believe in rebirth. So, and we believe in law of karma. Because of this law of karma and the unity, everything comes back. So in that way, in that sense, doctors have a noble duty to help others. Not just doctors, everyone have a noble duty to help others. And doctor especially, because they have got knowledge, they have got resources, and they can help others save life. And how? Again, I will say that we have to start small. And I said, you don't need to do much, but you have to cultivate this attitude. What is missing is the attitude is not there. I say that our Indians, they don't have, we Sadhu community, our monks community is really very worried, because the day by day we are seeing the society. Earlier we had this hardikta, sahridayata, but the day by day we are seeing the new generation that is coming. They are missing this emotional approach. They are missing this charity, the aspect of charity. So what we want is these small things. You should have empathy for your patients. This is very important. See, I'm not just saying you have to behave properly. You should really feel this. When the feeling will be there, you will also speak politely. You will also love your patient, and you will be sincere. What if we don't want that? You should spend enough time or more time to with the patient. Though some will say yes, to talk with to deal with students, you have to spend time, right? But I know that our Indian doctors do not have much time with them. They have to, for example, in 1 hour, they have to see 10, 15 patients. So each patient 5 minutes, or a maximum 3 minutes, 4 minutes, they have to see. They have to, and I know that they are capable people, because they are seeing so many patients throughout their life. Even if they are kind of not so capable when they are studying in their colleges or in the universities, but as they go to the practice of medicine, as they see so many patients, they become expert in few years. So I know that they are very capable people. So they can actually see the problem by seeing few reports. But I say behavior, because I don't have to tell you. You know that you day after day talking with patients and by strangers actually. See, the thing is, we feel, why do we feel irritated? When we talk with strangers, generally this irritation will come. And doctors, all the time, they are talking with the strangers, and many strangers. So that is why this irritation, this is studied in the psychology. Psychology can tell you why you feel irritated. But when you can control it, and when you really care about your patients, you are sincere about it, it will go away. So this feeling should come. This attitude should come. As a monk, as a spiritual person, I say there is certain truth to it. And it's not just you have to act like that, because there is also underlying unity. Eko Brahma Dvitiyo Nasti. I am Atma Brahma. Everyone, you are Soham. You are that. Everyone is only you. There is no other. Eko Aham Dvitiyo Nasti. And because of that, you are the doctor, you are the patient. But even if you don't know that, or even don't believe that, because it is true, that is why whatever help you will give, you will come to, that will come back to you, and that basis for being, for having empathy and having this, and to have, you can feel one with your patient, and this feeling of unity will come to you, and because of that you will do your duties properly. With this, I will finish the few words that I wanted to you. Thank you very much. I am very honored to be invited in this prestigious occasion, the 50th workshop that has been organized by Eastern Railway. Yes, thank you very much.
Thank you, Swamiji, for your words. It is time for felicitation of two of our hospital staff for outstanding performance in their sphere of work and sincere devotion to duty in the year 2024-25. Dr. Dipidash Gupta Memorial Award, instituted in the memory of a legendary and ex-senior physician of the hospital, comprises a certificate of merit and a cash award of Rs 2,000. I now take the pleasure of requesting our distinguished General Manager, Eastern Railway, Sri Milind Deoskar, to kindly present the awards to Srimati Nilima Majumdar, Chief Nursing Superintendent, B.R. Singh Hospital, and Sri Rajiv Kumar Shaw, Hospital Assistants. Both the awardees are requested to kindly come onto the stage and receive the awards from General Manager, Eastern Railway. Mr. Rajiv Kumar Shaw, Hospital Assistant, will be receiving the DP Dashgupta Memorial Award from our General Manager. Thank you, sir. It was our pleasure for having done the honors. And it is now time for us to listen to our respected General Manager with years of experience of working in the railways. Let me take the privilege of inviting sir for addressing this evening's gathering.
Good evening. Respected Dr. Usha Chandra, wife of DG RHS, Shri Jagdish Chandra, DG RHS, our AGM, Eastern Railway, PCMD, our Swami Sarvottamanand Ji, DRM Sialda, DRM Howrah, all the ladies and gentlemen. My situation is also similar. I am not a doctor, I am engineer, but I am a manager. Instead of engineer, I will say that I am a manager, and I am more concerned about the management of the health services and how a delight can be created to railway employees who are working day in, day out for Indian Railways. The duties are very, very demanding. Running staff, they are constantly under stress. If they commit one mistake, they maybe they lose their job, or they have got severe financial penalties. The duties are of shift type, so they cannot establish a proper sleeping pattern. Maybe loco pilots. There is a constant work stress, like working on the track, so they have to be constantly alert. The job in the workshops is also equally challenging. Very hard work is involved. So physical fitness, not only health, but physical fitness is also very important. So when it was said that when this conference was there, I requested Dr. Guha not to invite me on the podium because I'll be giving a lot many advices, probably may not, your mind may say that what is all this thing, because doctors are always, you can say, I have closely observed doctors when my close relatives were sick, and my grandfather, my grandmother, and my father. I had a lot of experience of you can say witnessing the doctors, their body language, the way they deal with. So I will agree with Swamiji that yes, emotional connect is very, very important. And notwithstanding that, there are a lot many patients. Notwithstanding that, see, when we expect a engineering department to look into thousands and lakhs of ERC clips, sleepers, say in 1 kilometer there are 6,500 ERC clips. There are lakhs of signaling gears. So, but here there are human beings. What we are seeing, we are giving many personal attention to so many equipments of Indian Railways. So we can definitely give more attention and more personalized attention to our railway employees, irrespective of the fact that there are many patients to be seen. I wish to make certain more points, basically from the patient perspective. I got it noted down so that I don't forget. Once I have been given an opportunity, let me speak my mind. And on behalf of patients, I don't want to lose any battle for them. I strongly feel that there is a need for educating patients about their problems. We had a wellness campaign last year, and as Dr. Nataraj told, that we identified some 6,500 plus hypertensives, and I think 6,500 diabetics and 9,000 plus hypertensives. So what if these things are not managed? Say, if you are diabetic, unless something seriously happens on a functional level, person will not bother. And a patient bothers when there is a functional level disturbance is there. But surprisingly, I find that the doctors bother when there is a disturbance at the pathological level, or maybe more at a structural level. So if somebody approaches a doctor with some complaint, the tests are ordered, and mostly the test will be normal, because at the functional level you will find any pathological change. To have some protocol at what level we should be going. By seeing the patient, one should be able to guess, or one should be able to identify out of the experience, clinical experience, that when I will get something in the pathology to look into it, when I will get it into the X-ray. So he is complaining, the patient is complaining, you order the report and see the report and say that you are good to go. After 3 months, 4 months, 5 months, then when his situation is very bad, then you see it in the report, and then you say that yes, you are now worthy of being treated. So maybe we need to do some brainstorming in this conference, that how to identify them at the initial level. And like what we have identified hypertensives and diabetics, we need to just say that what are the do's and don'ts. If you do not maintain your sugar level, what can happen? What to look for? Some issues in your kidney, some issues in your eyes, some issue elsewhere, some weight loss, something you need to tell that these are the vital signs which will indicate deviation from health, and then you give them a guidance and handhold them for times to come. Because of course there is no cure for all these lifestyle diseases, but how to manage them, they need to be taught. Secondly, this use of technology, as Swamiji has said, there are say when we look into some lung X-ray, today we don't find that there is a cancer, but after 5 months you say that yes, it's a cancer. Now there are a lot of, I think I read somewhere that there are machine learning models which is telling that incipient X-rays which when shown there, they project that yes, there is going to be some problem for some serious disease. So we need to introduce technology at a higher level. Today we saw MRI being installed. So this is somewhat, you can say, it will come at a later stage, but as early as we can detect the sickness, that might be of help to detect life-threatening diseases like cancer, TB. Now we have computerized. Third point which I want to make is that we have computerized our patients, you can say, data and all that, meet cards. Really we need to have some control over what is happening to that patient, and instead of just putting it and entering it, patients coming with a thick file which no doctor has got time to see. Only the patient feels that he has got so many tests done in the past and all that. Nobody is seeing that what is his normal blood report and how the blood report has changed in his sickness. That unless the doctors see to it and correlate, I think this carrying thick files by these ignorant patients is useless. I think once in today's perspective, you see a blood report, doctor says it's okay. Maybe he doesn't see the blood report also. One should just tear it and throw it in the dustbin. Next time you go, you have another blood report. So we need to have something with the computerization and how we can think of using old reports to establish some need for doctors consulting each other. This is the another point which I want to make. One doctor sees a patient, he has got certain doubt, he will just mark it to another specialist. He will mark to another specialist. Then there is no end to it. Instead, why doesn't a doctor give a single window clearance and satisfy himself? Uh, there has to be certain you can say coordination at the doctor's level, instead expecting from the patients that he will coordinate with the multiple specialties and then think of achieving health. Another point which I want to make is that, which is of course whatever I have been saying, another way of saying it is that our approach of providing health is a transactional type. We need to provide it in a relationship way, and because our doctors are not here to make business, they don't have any targets to achieve this much uh, finances for the hospital. We can really think of something holistic way, and with DGRHS coming here, we expect that how we can create a model for different types of diseases, different types of categories of staff, geography. We need to have some relationship based approach to the health provision. I think that's enough. There may be certain points which you may not agree, but I only request this gathering, August gathering of us, to think over whether we are able to solve it or not. But there is a problem. We have to create delight for the patients, and I expect that we, in such conferences, we share not only our clinical experiences and other technological advances, we also share the way in which somebody has managed the health of a larger community. I wish this conference a great success. Thank you very much.
Thank you, sir, for your words and feelings requiring introspection at our end. It is time to take a break from the solemnity of the occasion, and we will be releasing a colorful souvenir highlighting the achievements of BR Singh Hospital and various divisions of the zone. And I take the privilege of requesting our chief guest of the evening, Director General Railway Health Services, Dr. Jagdish Chandra, for releasing the souvenir published on this occasion. Dr. Jagdish Chandra, Director General Railway Health Services and highest executive of the Medical Department in Indian Railways and chief guest of the evening, will be delivering his speech now. With his vast experience and knowledge of working in the railways, and for providing vision and advice and inspiration to the serving officers as well as the next generation medical officers. I hope he will be able to provide a roadmap to future working in the railways, as it is definitely poised for a drastic change and reform in the coming decade. Sir, may kindly step forward and deliver your address.
Good evening. Dignitaries on the dais, Shri Milind Devaskar sir, GM Eastern Railway, Swamiji, Vice Chancellors, Vivekananda University, PCMD Eastern Railway, MD BR Singh Hospital, DRM Sialda, and Organizing Secretary Dr. Sharmistra of IRHSA. Of the dais, AGM Eastern Railway, DRM Howrah, PCMDs from other zones, PCMOs from production units, CMSS, senior doctors, residents of BR Singh Hospital, ladies and gentlemen. It is a matter of pride that I have been given opportunity to attend this conference of Indian Railway Health Services Association. Incidentally, I happen to be the president of this association, esteemed association. So this occasion is very close to my heart. So thank you very much for calling me and giving this opportunity. The theme of this scientific seminar and CME is very aptly and very importantly as comprehensive patient care, where discipline meets. As Swamiji has stated in his address, although he is not a doctor, but he made all the dignitaries address all the people sitting on the dais as doctors. So this is the beauty of our profession. And he talked about various disciplines. He himself is a computer engineer. And we, the organizers of this conference, tried to leverage the modern technology in our patient care. And for that, today we had a state-of-the-art, very high-end digital modality, that is 3 Tesla MRI, which has been inaugurated in Eastern Railway, first of its kind in Indian Railways. This is really a matter of great pride. So thank you very much. And congratulations to Eastern Railway for having such a cutting-edge technology in their hands. As we are in a noble profession and everybody expects something special out of us, and that is our endeavor to our beneficiaries to offer them best possible which we can provide to them. As we are working in a very different and very special industrial setup which runs 24/7, irrespective of any weather, any time, any season. Rather, our responsibility changes and everybody either in festive mood or holidays, then our duty enhances to manifold. Recently, we had Chhat Puja management, and our fraternity, our railwaymen have performed outstandingly, and we were up to the mark to our passengers. So this is the beauty of our organization. This is possible because of our employees are very special, very committed. And we are putting our efforts in, we are the guardian of their health. GM sir has talked about there should be approach to preventive aspect. When disease shows symptoms, the patient's visits to doctor. So before the disease is established, we should focus ourselves, our system, preventive healthcare also. As our mission statement shows that we are committed to comprehensive healthcare to our beneficiaries from preventive to curative and promotive. We are committed to holistic healthcare, not only merely by physical health, but emotional health also. Because our system is very much demanding and our employees are working in very hard conditions. GM sir mentioned about the responsibilities of loco pilots. They are most of the time they are not having proper sleep, not having proper food. As our previous data of preventive health checkup showed us that lot many subclinical unknown cases were there in the system, hypertension, diabetes, and other non-communicable diseases. When these employees never thought of, I may be having this problem, but this railway did a very commendable job, and same thing was replicated all over the IR. We had lot many preventive health checkup camps, and we could detect so many underlying diseases. As you know that we are leveraging technology into the healthcare system also. HIMS is there. We are just trying to develop it further. Recently, I met a representative from WHO. They wanted to have access to our data system so that they can define, they can do some research, which type of diseases are common in which areas and why. So we are working on that. So definitely we will be taking new technologies, computerization, digitization, everything into our system. Something about BR Singh Hospital, that this is one of the premier hospital of Indian Railways. And it has got a glorious history, and addition of new modalities like MRI and this blood bank getting cell separator is going to add up further facilities to the beneficiaries of not only in Eastern Railway, but adjoining Southeastern Railway and NF Railway as well. So I thank to the management of the Eastern Railway GM sir for considering the modern requirement of medical equipment to this esteemed hospital. This hospital is having cath lab, nephrology unit, cardiac surgery, and neuro ICUs also. As a new venture, the government is trying to enhance the medical seats as this big country requires more and more doctors and specialists. To support that idea, Railway is also working on that. So initially, about 10 zonal hospitals were chosen to start postgraduate medical seats. For the contribution to national statistics of creating more PG seats, so I am happy to share you that we have succeeded to a great extent. Has been given letter of permission to start postgraduate seats in multi specialties. So this is a very proud moment that we will take our hospitals to the teaching field also by upgrading our facilities infrastructure. We will be having more working hands with us. So this is being done from the board level, and the board thinks that there should be some standardization of the healthcare facilities, that every health unit should, division or zonal hospital should have required infrastructure, manpower, and various specialties, so that we can minimize referral to outside. And moreover, as GM sir stated in his address, that our beneficiary needs special compassion and connect. We were very much connected in past. Due to some or other reasons, there were some changes in that our beneficiaries wanted to take healthcare from outside hospitals. Now they have gone through that experience, and their idea has been changed, and they want to return back to our system. Want all sorts of required facilities in our healthcare setup only. We are having many qualified specialists and super specialist doctors in the system. The availability of manpower, human resource, and availability of the resources, they are contributory to each other. If you have a good infrastructure, any specialist can start working from day one. We have to change our approach. We have to develop our hospitals, our medical equipments, our buildings, and other things, so that if any new recruit comes to our system, he or she should get working environment, so that they can start functioning as specialists to their full potential. Lot many doctors are just joining, and once they find that we are not having proper system like OTs, equipments, and other things, then they feel themselves disenchanted from the system and they try to leave the system. So lot many zones are having many specialists who have just joined and not working in the system, and they have gone back either to private setups or to some mm, other institutions. So this has to be dealt by all the PCMDs. They should have personal contact to the specialists and new doctors who are coming to join our system, and they have to be assured that everything will be made available to them so that they can utilize their specialization or competence for the benefit of our beneficiaries. So I will request that this shortage of doctors should be addressed by all the senior people. Wherever I go, uh, I get this complaint that we are short of so many doctors. Doctors are there in the system, but physically they are not available. Either they are absconding or some other reason. We are very liberal for granting them to study leave, sponsorship. We are considerate to their postings also. We are trying to make some policies that their concerns are taken care of. The best way is to have good communication with them, explain them that your potential will be utilized to full extent. So that's how we can retain them in our system. At the end, I will say that comprehensive patient care demand, this is a very genuine demand. And we look beyond symptoms and diseases to see the individuals as a whole, integrating physical, emotional, psychological, and social dimensions of the health. Again, this holistic approach calls for teamwork among physicians, our paramedics, therapists, researchers, technologists, each of them contributing their unique expertise to shared goal of healing. May this conference spark meaningful discussions, nurture collaboration, and strengthen our shared mission of serving humanity through compassion and comprehensive healthcare. I wish the event grant success and all participants a truly enriching experience. Thank you very much.
Thank you. Hi. Thank you, sir, for your words of vision and prophecy, which I feel should come true in the years to come. So, as is the tradition, and keeping in line with the rich cultural heritage, we offer our thanksgiving to our guests, our dignitaries on and off the dais, and Dr. Shormishta Mukhopadhyay, Secretary, IRHC BR Singh Hospital, will be performing the tedious yet pleasant task of proposing the vote of thanks after which we will be calling off this evening's program.
Respected dignitaries on the dais and off the dais, on behalf of the organizing committee, I feel deeply honored to deliver vote of thanks on the auspicious occasion of inaugural ceremony of 50th annual conference of Bia Singh Hospital. Bia Singh Hospital is always in limelight for its clinical and academic excellence, and its annual conference is always a rich legacy of academic exchange, collaboration, and innovation. Its heritage lies not only in the quality of scientific contents, but also unity and commitment that continues to foster across generations. This year's theme of the conference, as already discussed, is comprehensive patient care, which we are going to materialize in our future life. I express my deepest gratitude to our chief guest, Mr. Jagdish Chandra, DGRHS sir, for accepting our invitation and adding prestige to this evening. Your inspiring words have set the perfect tone of the conference, sir. I express my heartfelt thanks to our President of Inauguration, Mr. Deoskar, Manager, Eastern Railway, for gracing the occasion and sharing his views and for his presence and his words. We are blessed that we have with us our President of Conference, Swami Sarvottomananda. Thank you, Swamiji, for your divine presence and enlightening words, which truly uplifted the spirit of the inaugural ceremony. I am really thankful to Dr. Nataraja Basappa, our PCMD sir, for your dignified presence, constant guidance, encouragement, and invaluable support throughout the journey. Your wisdom continues to be a pillar for us, sir. I am grateful to Mr. Rajiv Saxena, our Divisional Railway Manager, for his distinguished presence and constant support. I extend my heartfelt gratitude to Dr. Debashish Guha, Medical Director, Bia Singh Hospital, for your deep involvement, constant guidance, unwavering support, and visionary leadership that have been instrumental in shaping this event, sir. I am grateful to all dignitaries, particularly our Assistant General Manager, Mr. S.P. Singh, DRM Haura, all PCMDs for their illustrious presence. My heartfelt thanks to Dr. Usha Chandra, Madam. My heartfelt thanks to the ERWWO President, Eastern Railway, Mrs. Seema Deoskar, Madam. ERWWO President, Shialda, Mrs. Nidhi Saxena, Madam. Dr. Uma Chandra, Dr. Usha Singh, Madam. Dr. Uma Nataraj, Madam. And also Dr. Sudeshna Lahiri, Madam, for their graceful presence. My sincere thanks to all the eminent faculties whose insights and expertise have added immense value and has truly elevated the scientific standard of the conference. Thanks to all the delegates to be here for your constant involvement. This is the most appropriate time to express my heartfelt gratitude to all the members of IRHSA for their constant cooperation, active participation, and energetic involvement to make the conference successful. I will not mention everyone's name separately, but I like special word of thanks to our very dynamic and dedicated Dr. Shan, whose tireless effort, enthusiasm, and proactive involvement played a key role in the smooth execution and success of the conference. I extend my sincere thanks to the engineering department, electrical department, S&T department, security, environment and housekeeping management, CPRO, office bearers, and other contributors who for their relentless effort to make our Golden Jubilee celebration a success. I sincerely apologize if there was any mistake from our side, and we are always amenable to your suggestions. I hope this conference will ignite new ideas, strengthen networks, and inspire continued efforts. Long live IRS HSA Bia Singh Hospital.
So after the vote of thanks, we wind up today's program, and I place a request to each of our guests to stay back for a gala cultural evening which will start in a very short while from now. Please do not leave your seats and kindly join us for a dinner with the program. Thank you for being a very wonderful and supportive audience.
The introduction. Before we set the stage, मैं जरा नीचे आ जाऊं. And just to know that all of you can hear me crystal clear, how many of you are from? जरा हाथ उठाएं यहाँ पर in the audience. How many people? That lady has a lovely smile. Yes. बस इतने ही लोग शहर में. आप लोग जरा हाथ उठाएं. My first request to each one of you is, can we have a huge round of applause, everyone in the auditorium? Come on. I want to hear a huge round of applause. I want to hear some energy in the audience. नहीं, मैंने कहा huge round of applause, which means everyone in the auditorium right now. Come on. Can we have a huge round of applause? Thank you. For those of you in Kolkata, आप लोग मुझे रेडियो पे सुनते हो, 94.3 FM रेडियो नशा पर. I come every morning, I say good morning to you. My name is, मैं कहता हूँ आपके साथ आपका दोस्त अरविंद. And I'm a huge Kishore Kumar fan. That's why I host Crazy for Kishore in 32 cities across the country, including Mumbai, including Delhi, including Kolkata. और मैं जहाँ पर हूँ वहाँ पर थोड़ा संगीत जरूर आएगा. सर बैठ जाइए. I love the hairstyle. I love the tashan that you have. We're going to have a beautiful evening lined up for you. Thank you so much for being such a patient and such a beautiful, lovely audience. We're just setting up the stage for you.
Hello.
Meanwhile, thank you so much, sir, for gracing the occasion. Sir, आप महाराष्ट्र से हैं Bombay, I do the show on Crazy for Kishore. I want you to tell me, how has your experience been in Kolkata so far? कैसा लगा आपको?
Yeah, it's great. Kolkata is more. Kolkata is culturally more vibrant city, and as compared to Mumbai, so I expect a better thing in Kolkata. Don't compare with Mumbai.
No. And so we have special surprises for you as we perform also. Can we have a round of applause for Sir? Sir, लेकिन because I'm the entertainment for the evening and I'm allowed to be a little less formal, have you learnt good Bangla words here? Nothing? Huh? Or have you Bengali sweets, traditional Bengali sweets हमारे? Yes? So sugar levels are in control, sir? Sugar levels are in control with all this Sandesh, Mishti Doi and Rasagullas. Thank you so much. Now, requesting everyone to get seated क्योंकि हमारा पहला performance शुरू होने वाला है. Please, everyone in the audience, settle down. Because आप settle down होंगे तब मैं ये पर्दा जो है इसको उठाकर I'm going to get the performers on stage once again. Okay. How many people in the audience want a little music to start off? हाथ उठाइए please. Okay. अच्छा, रिक्वेस्ट है और गुजारिश है कि अगर आप लोग सब बैठ जाएं. मेरी आवाज काफी बुलंद है. आई एम श्योर आपके दिल तक पहुंच रही है. प्लीज सिट डाउन wherever you are so that now I can see everyone settling down slowly. Thank you so much. अगर आप थोड़ा सेटल डाउन हो जाएं तो फिर आज के शाम की हम शुरुआत कर सकते हैं. But before I start, it's a heartfelt welcome to each and every single person in the audience. The heroes in white coats. I wrote this for you backstage. The hearts that heal and the hands that never give up. I have a special connection with this wonderful place here, जहाँ पर मैं आज खड़े होके show कर रहा हूँ. And I've traveled across the globe, but I can tell you, there's a bit of nostalgia because I come from the family of Indian Railways. My grandfather was the chairman for the first planning commission from the East. And when my mother got to know, I did not know this, but इसी hospital में उनका जन्म हुआ था a couple of years back, which is like a long time back. So it feels a little bit of a homecoming for me कि यहाँ पर मैं वापस आया हूँ, knowing that half of my family, including all my mothers and her sisters, were all born in this very hospital. My great grandmother, she breathed the last of this wonderful place. So this has a very strong emotional connection for me. देखिए, इस हॉस्पिटल के बारे में आपको पता है, इस हॉस्पिटल का इतिहास आपको पता है. There is nothing that needs to be said or nothing that needs to be expressed in my own words. मैं सिर्फ आपको एक ही गुजारिश करूंगा as a presenter is let's look back at the history, enjoy the present and look to the future, embrace the technology, but more importantly, embrace a lovely musical evening. Because you've had such a long day with, a wonderful, wonderful confluence of ideas and get-togethers and exchanges. क्या मैं रिक्वेस्ट कर सकता हूं कि आज अगर म्यूजिक होगा तो आपके यहां से तालियां आएंगी? बस इतना हाँ या ना में बोल दीजिए. हाँ या ना? हाँ या ना? सिर्फ फ्रंट रो में मुझे हाँ सुनाई दे रही है. मिडिल वाले बस खाने में थोड़ा बिजी हैं. हाँ या ना? अब मिडिल वाले बोल रहे हैं लेकिन पीछे वाले ज्यादा नहीं बोल रहे. मैं कह रहा हूं डांसर्स रेडी हैं, उनको मोटिवेशन के लिए एक राउंड ऑफ अप्लॉज की जरूरत है. आप लोग तालियों से उनका स्वागत करोगे, हाँ या ना? गुड. ओके, हाउ मेनी किशोर कुमार फैंस इन द हाउस? हाथ उठाएं. हाउ मेनी आर.डी. बर्मन फैंस इन द हाउस? जरा हाथ उठाएं. हाउ मेनी उदित नारायण कुमार शानू फैंस इन द हाउस? हाथ उठाएं. गुड. आपको अगर मैं एक प्रॉमिस करूं कि आज जो बैंड है स्टेज पे परफॉर्म करने वाला है, दे हैव म्यूजिक फॉर ऑल जनरेशंस. सिर्फ पुराने गाने नहीं, we have an entire playlist that's specially curated for each one of you to enjoy. Once again, ladies and gentlemen, with just a couple of minutes and a couple of seconds, from starting right now, I'm going to go very quickly backstage and check and hopefully, get the curtains up and the dance ready for you. Okay, the good news is मुझे थोड़ा पीछे जाना पड़ा, लेकिन हमने वो काम कर दिया जिसका आपको बेसब्री से इंतजार था, which is get the stage ready. Can we have the lights dimmed in the audience? थोड़ा सा लाइट अगर आप कम कर दें ज्यादा अच्छा होगा. Whoever is managing the lights, थोड़ा सा lights in the audience उसको dim कर दीजिए, because we're starting with the cultural evening. Okay, with a very, 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 very huge round of applause. Once again, I request each one of you, नित्यांकुर, जो डांसिंग को आपके जिंदगी में और ज्यादा कलरफुल करता है, दैट्स द नेम ऑफ द ग्रुप व्हिच इज गोइंग टू परफॉर्म फर्स्ट राइट नाउ. ऐसा डांस ग्रुप है जो कल्याणी से है. नदिया कोरियोग्राफर एंड डांस डायरेक्टर, चंदन गोस्वामी असिस्टेंट कोरियोग्राफर ऑफ डांस बांग्ला डांस व्हिच यू कैन सी ऑन जी बांग्ला, and representative of the West Bengal Dance Group Federation from Nadia district. They've traveled far, they've worked hard, and they've been waiting very, very patiently to entertain each one of you. Requesting each one of you in the audience to give them a huge round of applause. Come on, तालियों से. मैं request कर रहा हूं आप सबसे कि एक जबरदस्त round of applause हो जाए. Thank you, so that we can get started with our first beautiful non-stop dance performance of the evening, जिसमें एक छोटा सा सरप्राइज है आपके लिए.
Everybody come on now. I believe in music. I believe in love. I believe in music. Yes, I do. I believe in love. One more time. I believe in music. I believe in love. I believe in music.
वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा. रिद्धि सिद्धि वृद्धि होती हाँ तेरे ही आने से, और सुंदर ये सृष्टि होती हाँ तेरे ही आने से। मोरया मोरया सिंदूर लाल चढ़ायो अच्छा गजमुख को, धूंधिल लाल विराजे सुत गौरी हर को, हाथ लिए गुड़ लड्डू साई सुरवर को, महिमा कहे न जाए लाखत हूँ पद को। जय देव जय देव जय जय जी गणराज विद्या संदाता, धन्य तुम्हारो दर्शन मेरा मन लुटा। जय देव जय देव भाव भक्ति से कोई शरणागत आवे, संपत्ति संपत्ति सब ही भरपूर पावे। ऐसे तुम महाराज को अति भावे, गोसावी नंदन निज दिल गुण गावे। जय देव जय देव जय जय जी गणराज विद्या सुखदाता, धन्य तुम्हारो दर्शन मेरा मन रमता। जय देव जय देव लुटांगण मंदिर चरण डोळ्यान पाहिन रूप तुझे, प्रेमे अलंगिन आनंद पूजन भावे वाळीन म्हणे नावा। त्वमेव माता पिता त्वमेव, त्वमेव बंधुश्च सखा त्वमेव, त्वमेव विद्या करुणं त्वमेव, त्वमेव सर्वं मम देव देव। कायेन वाचा मनसेन्द्रियैर्वा बुद्ध्यात्मना वा प्रकृति स्वभाव, करोमि यत् सकलं परस्मै नारायणाय समर्पयामि। अच्युतं केशवं रामनारायणं कृष्णदामोदरं वासुदेवं हरि, इंद्रं माधवं गोपिकावल्लभं जानकी नायकं रामचन्द्रं भजे। हरे राम 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 हरे हरे, हरे कृष्ण 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 हरे हरे, हरे राम राम हरे हरे, हरे कृष्ण 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 हरे हरे, हरे राम हरे कृष्ण कृष्ण हरे हरे, हरे राम राम हरे कृष्ण हरे राम हरे कृष्ण
In the heart of Bengal, where rivers weave through golden paddy fields, the sound of folk music flows like a living soul. Long before modern instruments and digital beats, villagers gathered under banyan trees, singing songs that spoke of love, sorrow, and devotion. The Bauls, wandering minstrels with ektaras in hand, sang of the divine hidden within every human heart. Their music carried a mystic message of unity and peace. In the fields, Batiali songs rose from the lips of boatmen as they rowed against the river's current, blending rhythm with the waves. Bawaya told tales of longing lovers from the northern plains, while Jhumar echoed the vibrant spirit of tribal dances in western Bengal. Each melody was simple yet profound, connecting people across caste and creed. Passed from one generation to another, Bengali folk music became a living heritage, a mirror of the people's joys and struggles. Even today, when the ball strums his ektara and sings beneath the open sky, the timeless music of Bengal still whispers. The soul of the land lives in its songs.
কইনার হাতের বালা কইনার সাথা বালা কইনার গলায় মালা কইনার মনু তলা এই হাতের বালা সাথা বালা ঝলমলে ঝলমলে বাজে গলায় মালা মনে হুতলা সুজন মনের মাঝে হলুদ পাটা নকশা কাটা তা পায়ে সাজে নুন কাটা চন্দন ফোটা সুখের সানায় বাজে বাজারে শাখ বাজা উলু দেহে ঘরে সাজা বাজারে শাখ বাজা উলু দেহে ঘরে সাজা খুশিতে ভরলো উঠনে রাঙা হলো রাজে হাতের বালা শাখা পালা ঝলমলে ঝলমলে বাজে গলায় মালা মনে হুতলা সুজন মনের মাঝে হলুদ পাতা নকশা কাটা আলতা পায়ে সাজে নুন কাটা চন্দন ফোটা সুখের সানায় বাজে এই হলুদ মেখে হোলি ঝিঙ্গা ফুল হলুদ মেখে হোলি ঝিঙ্গা ফুল এই কার সোহাগে প্রেম বরাগে হোলি দেয়া কল গলায় দিলি এখন মালা ঝুমকা কানে দোল ভুলালি মন ভুলালি সাজালি রূপের ডালি ভুলালি মন ভুলালি সাজালি রূপের ডালি বারে বারে নজর খালি তোর দিকে যাচ্ছে হাতের বালা ওই হই হাতের বালা সাকা পালা ঝলমলে ঝলমলে বাজে গলায় মালা মনে হুতলা সুজন মনের মাঝে হলুদ বাটা নকশা কাটা আলতা পায়ে সাজে নুন কাটা চন্দন ফোটা সুখের সানায় বাজে ছাতনা তলায় চিকন থালা চারিয়ে দেখে যা বরুণ ডালা উঠোনে থালা সাজা রে সাজা এই ছাতনা তলায় চিকন কালা চারিয়ে দেখে যা বরুণ ডালা উঠোনে থালা সাজা রে সাজা এই বাজারে শাখ বাজা হলুদে ঘরে সাজা বাজারে শাখ বাজা হলুদে ঘরে সাজা এই মধুর খুশির লগন যুগল মিলন মাঝে হাতের বালা ওই হই হাতের বালা শাখা পালা ঝলমলে ঝলমলে বাজে গলায় মালা মনে হুতলা সুজন মনের মাঝে হলুদ বাটা নকশা কাটা আলতা পায়ে সাজে নুন কাটা চন্দন ফোটা সুখের সানায় বাজে
সনাতন ধর্মের প্রাণপুরুষ ভগবান শ্রীকৃষ্ণ এই ধরাধামে আবির্ভূত হন দুষ্টের দমনে, শিষ্টের পালনে।
প্রলয়ঙ্করী পৃথিবী থেকে পাপ মোচন করে ধর্ম স্থাপনের লক্ষ্যে তার বিকাশ এই ধরিত্রীর বুকে।
তাঁর জীবন লীলা অপার, অবর্ণনীয়। তবে বিশেষ এক অধ্যায় নিয়ে আমাদের এই নিবেদন। কৃষ্ণ ভোলবার পর সবাই ভুলেছে তোকে, কেউ আর মনেও রাখেনি।
আমি গোঠে মাঠে বাটে ধবলি চড়াই, রাই তোমার প্রেমের কি বা জানি।
রাধা কৃষ্ণের প্রেম গাথা আমাদের সকলেরই জানা। বিশ্বের দরবারে চির অমর শ্রী রাধিকা আর কানাইয়ের কাহিনী।
রাধার কৃষ্ণ হোক বা কৃষ্ণের রাধা, রাধা কৃষ্ণ এক আত্মা, এক প্রাণ।
কিন্তু মীরা, সে তো আজীবন পূজন করেছে তার প্রিয়নাথ কৃষ্ণকে।
মনে প্রাণে শয়নে স্বপনে মীরার একমাত্র পূজন সঙ্গী কৃষ্ণমূর্তি।
নৃত্যাঙ্কুর ডান্স একাডেমির এবারের নিবেদনে পাবেন এমনই এক বিশেষ প্রেম কাহিনী।
এবারের নিবেদন কৃষ্ণ পূজনে রাধা মীরা।
मेरे ढोल ना सुन, मेरे प्यार की धुन, मेरे ढोल ना सुन। मेरे ढोल ना सुन, मेरे प्यार की धुन, मेरे ढोल ना सुन, मेरी चाहते तो फिजा में बहेगी, जिंदा रहेगी होके फना। আমি যে তোমার, শুধু যে তোমার, আমি যে তোমার। साथी रे मरती भी तुझको चाहेगा दिल, तुझे ही बेचैनियों में आएगा दिल। साथी रे मरती भी तुझको चाहेगा दिल, तुझे ही बेचैनियों में आएगा दिल। मेरे गीतों की साए में तेरी राहतों की खुशबू है, तेरे बगैर क्या जीना। मेरे रोम रोम में तू है, मेरी चूड़ियों की खन खन से तेरी सदाएं आती है। ये दूरियां हमेशा ही नजदीक हमको लाती है।
सानिधा निधम मग सनि धनि सगम मग सनि धनि सगम ग सनि धनि सगम ग म ग सनि ध मग मदनि सनि ध मग मदनि सा नि ध नि धनि स धनि स धनि स धनि स मद మదని 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 ధనిస 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 మదని 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 మదనిస 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 సనిదమ 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 మమగగ సనిని సనిని దదని సనిని దద మమగగ సనిని దద আমি যে তোমার শুধু যে তোমার আমি যে তোমার सांसों में तेरे सरगमे हैं अब रात दिन जिंदगी मेरी तो कुछ ना अब तेरे बिन सांसों में तेरी सरगमे हैं अब रात दिन जिंदगी मेरी तो कुछ ना अब तेरे बिन धड़कनों की सरगोशी मेरी धड़कनों में बजती है मेरी जागती निगाहों में ख्वाहिश तेरी ही सजती है मेरे ख्याल में हर पल तेरे ख्याल शामिल है लम्हे जुदाइयों वाले मुश्किल बड़े ही मुश्किल है मेरे ढोलना सुन मेरे प्यार की धुन मेरे ढोलना
Garba. Garba is derived from Sanskrit term garb, which means womb. Garba is the folk dance of Gujarat performed around the statue of goddess Durga or the pot with lamp lit inside it, called Garbhdeep, which represents life just as a fetus in the mother's womb. Now, let's talk about Dandiya dance. In this dance, both men and women energetically dance with colorful and decorated bamboo sticks, striking them to the beats of instruments like the dholak and tabla. The dance is a beautiful way of recreating the battle that took place between the Devi and the demon.
रंगीला भारो ढोलना ढोलना बे रंगीला भारो ढोलना ढोलना बे आरा आयो रे
प्यार के गीत जरा सुन ले, ओ प्यार के गीत जरा सुन ले, मैं आया रे।
Vande Mataram. Sujalam Sufalam Malayaja Sheetalam. Salutations to you, O Mother. You are blessed with richness in water resources, plenty of fruits and forest resources, and flushed with cool air breezing from Malaya mountains. Shashya Shyamalam Mataram. Vande Mataram. Green with rice plants, O our motherland. Salutations to you, our mother. Shubhra Jyotsna Pulakita Yaminim. Fulla Kusumita Drumatala Shobhini. Where nights are made joyous by sparkling light, very beautiful by buds, flowers, and rows of trees. Suhasinim, Sumadura Bhashinim, Sukadham Varadam Mataram, Vande Mataram. Always looking pleasant, sweet speaking, giver of happiness and riches, O our motherland. Salutations to you, O mother.
Vande Mataram. Vande Mataram. वन्दे मातरम् वन्दे मातरम् सुजला सुफला मलयज शीतला सश्यामला मातरम् वन्दे मातरम् वन्दे मातरम् रे म प नि न प म प म रे म प स नि नि सा म नि स नि स नि नि द प म प म नि स नि स रे म शुभ्र ज्योत्स्ना पुलकित यामिनी फूल कुसुमित द्रुमदर शोभिनी शुभ्र ज्योत्स्ना पुलकित यामिनी फूल कुसुमित द्रुमदर शोभिनी सुहासिनी सुमधुर भाषिणी सुखदां वरदां मातरं वन्दे मातरं वन्दे मातरं वन्दे मातरं वन्दे मातरम्
অহরহ তব আহ্বান প্রচারিত শুনি তব উদার বাণী হিন্দু বৌদ্ধ শিখ জৈন পারসিক মুসলমান খ্রিস্টানি
পূরব পশ্চিম আসে তব সিংহাসন পাশে প্রেম হার হয় গাথা জনগণ ঐক্য বিধায়ক জয় হে ভারত ভাগ্য বিধাতা
পতন অভ্যুদয় বন্ধুর পন্থা যুগ যুগ ধাবিত যাত্রী হে চির সারথি তব রথ চক্রে মুখরিত পথ দিন রাত্রি
দারুণ বিপ্লব মাঝে তব শঙ্খ ধ্বনি বাজে
সংকট দুঃখ ত্রাতা জনগণ পথ পরিচায়ক জয় হে ভারত ভাগ্য বিধাতা জয় হে জয় হে জয়
Check. Thank you so much. It would be very safe to say this kind of a performance इसके लिए एक standing round of applause भी बन सकता है. Come on everyone for the lovely performance that all of them have done. And they come all the way from Kalyani. कितने दूर से आप लोगों को जो दिखा, it was not just a dance performance but hours and hours of hard work. जो performers behind the scene enact करते हैं, they try. और यहाँ पर जब inauguration ceremony चल रही थी ना, they were constantly debating and discussing ये करना है इस गाने के बाद ऐसे करना है. And I think Judge Chandanda right there in the center, he is of course the founder of the group Nrityankur. ये नाम याद रखेगा. They represent Kalyani, but it would be fair to say I think they represent Bharat in every true sense of the term. उनके कला उनके प्रदर्शन के साथ. Huge round of applause. They really got this entire evening alive. Thank you so much. Thank you so much. After this lovely dance performance from Nrityankur, now I have an incredible special surprise for you. Koto jo nacho, let me say this in Bangla या फिर हिंदी में पूछता हूँ, my energy is back. एक रेडियो जॉकी ना जब म्यूजिक सुनता है तो automatically the energy is back for him. How many of you want a little live music in the house? एक तो हाथ तली दाओ. Come on. Live music चाहो कि ना? Yes or no? Yes or no? जब ऐसा कोई इवेंट होता है और पीछे वालों का जो एनर्जी है वो थोड़ा हाई हो जाता है, इस मतलब ये समझ में आता है कि वहां 2 पैक ज्यादा एक्स्ट्रा गए हैं. और जहां से एनर्जी थोड़ी कम आ रही है, उनके साइलेंस में मुझे गुस्सा नजर आता है कि हम 2 पैक से ज्यादा क्यों नहीं जा पाए. लेकिन मैं कहता हूं द रियल इंटॉक्सिकेशन यानी असली नशा जो है ना इज ऑलवेज इन द परफॉर्मेंस ऑन स्टेज. और यहाँ पर जितने कलाकार आज आएंगे दे कम ओनली फॉर यू. मैं आज एक बहुत ही स्पेशल बैंड के साथ आपको इंट्रोड्यूस करने वाला हूँ. सर इनका नाम भी बहुत प्यारा है क्योंकि नाम ऐसा जो हमारे दिल के बिल्कुल करीब. दे कॉल देमसेल्व्स देश. अब आप कहोगे यार ये देश कैसा नाम है. आई मीन अ बैंड शुड हैव अ फैंसी नेम राइट. लेकिन भारत को अगर कोई ब्रांड रिप्रेजेंट करता है, और आज ये जो बैंड है बंगाली से शुरू करके हर भाषा में हर लैंग्वेज में आपको एंटरटेन कर सकता है, फ्रॉम ऑल जॉनर्स फ्रॉम ऑल जनरेशंस. अब बैंड में कुछ गाने वाले लोग भी हैं और ये ऐसा बैंड है which has performed around the world. I mean not just India, not just West Bengal, but I'm talking the entire world for more than 15 years now. Shamik Kundu मेरे बहुत प्यारे मित्र हैं and one of the front faces of the band. और लड़कियों को बता दूं काफी handsome भी हैं. Was nominated for the Oscars in 2024. Can we have a huge round of applause to that? You have a very special performer here on stage who was nominated for the Oscars and is a very versatile singer, very good composer, excellent lyricist, filmmaker, and a multi-instrumentalist. To his credit, 300 से ज़्यादा compositions हैं, and he is the voice behind hit national TV jingles like Box Cricket League जो आपने बालाजी टेलीफिल्म्स का सुना होगा, या फिर झारखंड टूरिज्म का जो anthem है वो इन्हीं की composition है, and so many other things. And of course, joining him on stage is another beautiful voice. वो कहते हैं ना वो शिव और शक्ति का यूनियन जो है बहुत पावरफुल होता है. तो if there is Shiv on stage with Shamik, there is Shakti with Shivli. What a lovely voice, ladies and gentlemen. To her credit, reality shows including Saregamapa, Hindi और Bengali, सुरों का एकलव्य, Indian Idol, आपने उनको टीवी पर देखा है, कई जगह पर स्टेज पे परफॉर्म करते हुए देखा है. But you know the best introduction that both of them can have? कलाकार स्टेज पे बहुत अच्छा परफॉर्म करे तो लोगों की तालियां पड़ती है, लेकिन यही कलाकार अगर बहुत अच्छा इंसान भी हो जो आपका दिल जीत जाए तो ये परफॉर्मेंस आपको हमेशा याद रहता है. You know, there's a little saying 20 मिनट की शोहरत हर कलाकार को मिलती है, but the performer who lives in your hearts forever. And whenever you listen to the song, आपको याद आता है शमिक शूली और देश का बैंड स्टेज पर था. We had a beautiful evening with them. अब आपके दिमाग में सिर्फ यही चल रहा है कि अरविंद भाई रेडियो पर तो आप जब बहुत ज्यादा बात करते हो हम आपको रोक नहीं सकते, लेकिन अब हम म्यूजिक सुनना चाहते हैं, हम बातें थोड़ी कम कीजिए एंड इंट्रोड्यूस द आर्टिस्ट ऑन स्टेज. लेकिन कलाकार तभी आएगा और आर्टिस्ट तभी आएगा जब एक ह्यूज थंडरस राउंड ऑफ अप्लॉज मुझे मिलेगा. कम ऑन एवरीवन, every member in the audience, और यहां से मैं सबको देख पा रहा हूं. I need more energy. Come on. अच्छा, so let's say 3 cheers for the family members of the railways, for all the doctors and the family members. Hip hip, hip hip, hip hip. और अब जो नशा है सारी जिंदगी और सारी उम्र आपको याद रहेगा. Ladies and gentlemen, put your hands together for Shamik and Shuli and of course the man Desh.
এই লিড গিটারটা অফ করো, লিড গিটারটা অফ করো। চলো করেছি। চলো দেখো। ভাই আছে, ভাই আছে, এলো তো এক্ষুনি। মিউট করো, মিউট করো, বেসটা মিউট করো। চলো দেখো। হ্যাঁ ডিরেক্ট দিয়েছি, দেখো। এসে চলো। ময়টা দাও, ময়টা দাও, ময়টা ছাড়ো। 2 নম্বর ময়টারটা দাও। একটু লেভেল বাড়াও। ওকে ওকে, আউটটা একটুখানি পরে বাড়িয়ে দিই। লিড গিটারটা আসো। হ্যাঁ চলো। কোনটা? মিউট করো, মিউট করো। আচ্ছা ততক্ষণ একটা লাইন খুলেছে, একটা লাইন দাও দেখি। যেটা খুলেছে ওটাই কি? কোনটা? ঠিক আছে, ঠিক আছে, ঠিক আছে, ঠিক আছে, তুমি প্যাডটা দেখো, প্যাডটা দেখো। ভেতরে হ্যাঁ ভেতরে দাও। মনিটর বাড়বে, মনিটর বাড়বে। এইটাই দাও, এইটাই দাও। এদিকেও দিও, ঠিক আছে? হ্যাঁ এদিকে আসতে দিও, এদিকে আসতে দাও। ইনিয়ারে দাও, ইনিয়ার ছাড়ো, ইনিয়ার দাও। রতনদার ইনিয়ারটা দাও। বাজাও বাজাও। ইনিয়ারটা কমবে, ইনিয়ারটা কমবে। আরো কমাও। হ্যাঁ ইনিয়ার, ইনিয়ার। ওহ কমবে ইনি আর কমবে ইনি আর কমবে ওকে 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 চলো ঢোল দেখো চাটি দেখো 1 নম্বর আগের টোনটা ঠিক ছিল ঠিক আছে এবার বাড়া দাও মইটা দাও বাড়া দাও আরেকটু দাও আরো দাও উঠবে আরো দাও বাড়া দাও বাড়া 2 নম্বর আছে বাড়াও মইটা দাও ইনি আর দাও আরো বাড়বে প্রচুর বাড়বে দাও পাঁচ আরে ঢোলটা এই মইটাটা দাওনি মইটা ছাড়ো হ্যাঁ এই মইটার গুলো ছেড়ে দাও সব হালকা করে দিয়ে দাও আটু দাও এইগুলো 2 3 4 5 হ্যাঁ আটু বাড়বে 4 নম্বর বাড়বে 3 4 বাড়বে বাড়াও আরে 3 4 5 দাও পাক্কা আছে
এবার আমার কানে কমা একটু
এবারে কানটা কমাও ঢোলটা ঠিক আছে কিবোর্ডটা একটু বাড়িয়ে দিও হ্যাঁ 3 নম্বরে চারে কিবোর্ডটা একটু বাড়বে কিবোর্ডটা আর একটু আরে 5টা কমাও 4-এ দাও ও বাবা হ্যাঁ 4-এ দাও পাঁচটা কমাও 4টা দাও 5টা কমাতে বলেছি 4টা দাও এই গিটারটা দেখো গিটারটা ঠিক আছে 5 তো পুরো কমে গেছে 5-এ দাও হ্যাঁ ঠিক আছে যাবে দেখো 5 নম্বর যাবে 5 6 করে দিয়ে দাও, কানে একটু দিয়ে দিও।
না দিলে বলতে পারিস না, ছেড়ে দে। এটা কাট।
কমাও কমাও কমাও। এই গিটারটা দেখো, গিটারটা দেখো, গিটারটা দেখো, লিড গিটারটা, লিড গিটারটা দেখো। হ্যাঁ কই না, এই মিউট করো, গিটার মিউট করো। দেখো দেখো লিড গিটার দেখো।
वो कहते हैं ना, अच्छी चीजों के लिए थोड़ा इंतजार करना पड़ता है। अब आपको इंतजार नहीं करना होगा। With a huge round of applause, ladies and gentlemen, please welcome Shomik Kundu, Shuli, and of course the band Desh.
Check, check. Level একটু প্লিজ এই মাইক্রোফোনে। রাজুদা একটু লেভেল লাগবে on this mic. Is it there? So without any further ado, we are already running way behind schedule. Let's get the game going. And obviously जब कुछ शुरू करते हैं तो गणेश जी का नाम लेके शुरू करते हैं, तो स्टार्टिंग में गणेश बनता था। Can I have a little reverb? Raju da reverb. देवा तुझा दारी आलो गुणगान गाया तुझाय ना मान साचा जन्मदाई गाया हे देवा दिलिहात उधार कराया आभाळाची छाया तुझी समुद्राची माया मोरया
मोरया मोरया मोरया मोरया मोरया मोरया मोरया मोरया मोरया मोरया मोरया मोरया मोरया मोरया
ओ देवा तुझी दारी आलो गुणगान गाया तुझ्या ना मानसाचा जन्मदारी वाया हे देवा दिली हाक उद्धार कराया आभाळाची छाया तुझी समुद्राची माया मोरया 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 रूप तुझा चार चार मंडे जाण येली पाना सगा फूल तुझ गंधी भाग्यताच्या पाठी राहा गरीबाचा वाली माझी भक्ती तुझी शक्ती एक रूप झाली हे देवा दिली हाक उद्धार कराया आभाळाची छाया तुझी समुद्राची माया मोरया 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 So from Maharashtra, my college life was in Pune, so I spent a pretty decent amount of time out there in Pune, Maharashtra, and Bombay as well. So let's come straight back to the city where I live right now, Kolkata. Moving on, we'll stick to the roots. We'll come with a folk number, and this one's going to be from the whole Bangla folk thing. Voice, guitar occupied on Rajuda? On all the monitors, please. Voice, guitar, and occupied. And also the bass guitar, please. Guitar to monitor down, please. Rajuda. Guitar, please. It's on the same place. Anyways, moving ahead. Bhubano Mohono Gana Tuki Jalar Manahara Bhubano Mohono Gana Gopi Jana Monohara জয় রাধার নামে পাগল হয়ে থাকবো মগনা জয় রাধার নামে পাগল হয়ে থাকবো মগনা না 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 ছেড়ে দেব না যারা বসে আছেন তারা একটু সঙ্গে সঙ্গে দিই, then we have the claps and the snaps and the beat piece. So তোমায় ঋতু মাঝারে রাখবো, ছেড়ে দেবো না, তোমায় পক্ষ মাঝে রাখবো, যেতে দেবো না, তোমায় ঋতু মাঝারে রাখবো, ছেড়ে দেবো না, না না না, পক্ষ মাঝে রাখবো, যেতে দেবো না। ছেড়ে দিলে সোনার গৌর আর তো পাবো না, বলি ছেড়ে দিলে সোনার গৌর আর তো পাবো না, না না না, যেতে দেবো না, তোমায় ঋতু মাঝারে রাখবো, ছেড়ে দেবো না, না না না, পক্ষ মাঝে রাখবো, যেতে দেবো না।
বলি ও ননদী আর দু মুঠো চাল ফেলে দে হাঁড়িতে, ও ননদী আর দু মুঠো চাল ফেলে দে হাঁড়িতে, ঠাকুর জামাই এলো বাড়িতে, ও ননদী ঠাকুর জামাই এলো বাড়িতে। বলি ও ননদী আর দু মুঠো চাল ফেলে দে হাঁড়িতে, ঠাকুর জামাই এলো বাড়িতে, ও ননদী ঠাকুর জামাই এলো বাড়িতে। স্টেশনের বাবুর মতো মিষ্টি পাখে, স্টেশনের বাবুর মতো মিষ্টি পাখে, দেখেন তোরে দেখছি কেমন, দেখেন তোরে দেখছি কেমন, জানতে পেয়েছি আমি তাই তো বলি, আমি তাই তো বলি চুল বেঁধে সাজ হলুদ রঙা শাড়িতে, ঠাকুর জামাই এলো বাড়িতে, ও ননদী ঠাকুর জামাই এলো বাড়িতে। বলি ও ননদী আর দু মুঠো চাল ফেলে দে হাঁড়িতে, ঠাকুর জামাই এলো বাড়িতে, ও ননদী ঠাকুর জামাই এলো বাড়িতে। বড় লোকের পিটিলো লম্বা লম্বা চুল, এমন মাথায় বেঁধে দেবো লাল গেঁদা ফুল। বড় লোকের পিটিলো লম্বা লম্বা চুল, এমন মাথায় বেঁধে দেবো লাল গেঁদা ফুল। দেখেছিলাম সরানে ওরে সরানে, দেখেছিলাম সরানে ওরে সরানে, আমার সঙ্গে দেখা হবে বাবুর বাগানে, আমার সঙ্গে দেখা হবে বাবুর বাগানে। বড় লোকের পিটিলো লম্বা লম্বা চুল, এমন মাথায় বেঁধে দেবো লাল গেঁদা ফুল। বড় লোকের পিটিলো লম্বা লম্বা চুল, এমন মাথায় বেঁধে দেবো লাল গেঁদা ফুল।
মাটির সরানে মন আমার রইল পড়ে জম্বনে আর নদীর পাশে নীল আকাশে, সেখানে ধুলোয় মাথা রইল পড়ে তোর চিঠি, বীরভূমের বিদির বল নাকি সাধু বিদির, বীরভূমের বিদির বল নাকি সাধু বিদির, না পেলে আমাকে আর তো কেউ আমি পেলাম না। ঝড়ে আম কুড়োয় এখনো কোন দোষী ছেলে, ঝড়ে আম কুড়োয় এখনো কোন দোষী ছেলে, আমার আর রাখার সাজা হলো না। লাল মাটির সরানে, ও লাল মাটির সরানে, আরে লাল মাটির সরানে।
বধু 3 দিন, বধু 3 দিন তোর বাড়িতে গেলাম, দেখা পাইলাম না। বধু 3 দিন কাম্বার হইতে ছড়ানা, ধীরাইতে ছড়ানা, কাম্বার হইতে ছড়ানা, ধীরাইতে ছড়ানা, আইতে যাইতে পারো আনা, উসুল হইল না। বধু 3 দিন, বধু 3 দিন তোর বাড়িতে গেলাম, দেখা পাইলাম না। বধু 3 দিন। শুভযাত্রা বৃহস্পতিবারে মালা শুক্রবারে প্রেম প্রীতি হয় না ষোলোয়ানা বুধবারে শুভযাত্রা বৃহস্পতিবারে মালা শুক্রবারে প্রেম প্রীতি হয় না ষোলোয়ানা শনিবারে গিয়া তোর দেখা পাইলাম না বন্ধু 3 দিন তোর বাড়িতে গেলাম দেখা পাইলাম না বন্ধু 3 দিন সোহাগ চাঁদ বদনি ধনি নাচো তো দেখি সোহাগ চাঁদ বদনি ধনি নাচো তো দেখি পালা নাচো তো দেখি সোহাগ চাঁদ বদনি ধনি নাচো তো দেখি সোহাগ চাঁদ বদনি ধনি নাচো তো দেখি
সোহাগ চাঁদ বদনি ধনি নাচো তো দেখি प्रीत की लत मोहे ऐसी लागी हो गई मैं मतवारी बल बल जाऊं अपने पिया को निम जाऊं बारी बारी मोहे तुझ बुध ना रही तन मन की ये तो जाने दुनिया सारी बेबस और लाचार फिरूं मैं हारी मैं दिल हारी मैं दिल हरी तेरे नाम से जी लूं तेरे नाम से मर जाऊं तेरे नाम से जी लूं तेरे नाम से मर जाऊं तेरे प्यार के सदके में कुछ ऐसा कर जाऊं तूने क्या कर डाला मर गई मैं मिट गई मैं हो जी हाँ जी हो गई मैं तेरी दीवानी दीवानी तेरी दीवानी दीवानी तूने क्या कर डाला मर गई मैं मिट गई मैं हो जी हाँ जी हो गई मैं तेरी दीवानी दीवानी तेरी दीवानी दीवानी इश्क जुनू जब हद से बढ़ जाए, इश्क जुनू जब हद से बढ़ जाए, हंसते हंसते आशिक दूरी चढ़ जाए। इश्क का जादू सर चढ़ कर बोले, इश्क का जादू सर चढ़ कर बोले, खूब लगा लो पहरे रस्ते रब खोले। यही इश्क दी मर्जी है, यही रब दी मर्जी है। ओ इश्क दी मर्जी है, यही रब दी मर्जी है। तेरे बिन जीना चाहता खुद करती है। तूने क्या कर डाला, मर गई मैं, मिट गई मैं, हो जी हाँ जी, हो गई मैं तेरी दीवानी, दीवानी तेरी दीवानी, दीवानी। आधी आधी जागी आधी आधी सोए, अब ये तेरी तो लगता है रोए, लेकर के नाम हमारा। रूठा रूठा रब छूटा छूटा सब, टूटा टूटा दिल तेरे लिए अब कैसे हो जीना गवारा। দেখ চুকি তারারাও যত আলো বর্ষ দূরে, তারও দূরে তুমি আর আমি যাই ক্রমে চলে চলে। না জানে কই ऐसी है ये जिंदगानी, जिंदगानी हमारी अधूरी कहानी। ना जाने कोई, ना जाने कोई हमारी अधूरी कहानी। Thank you so much. The song is especially dedicated to the folks who've come all the way from the northern part of India. It's a tribute to none other than the great Nusrat Fateh Ali Khan Sahab. नैनों ने थारी कैसा जादू किया रे, नैनों ने थारी कैसा जादू किया रे। थारे बिना लगे नहीं भरा जिया रे, ओ थारे बिना लगे नहीं भरा जिया रे। पिया रे 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 पिया रे, थारे बिना लगे नहीं भरा जिया रे, ओ घर बिन लगे नहीं मारा जिया रे घर बिन मोहे चैन ना आवे धक 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 मारा जी घबरावे घर बिन मोहे चैन ना आवे धक 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 मारा जी घबरावे बोले बांसुरिया सुन रे सावरिया बोले बांसुरिया सुन रे सावरिया हर बिना मोहे कुछ नहीं भावे पिया रे पिया रे पिया रे पिया रे घर बिना लगे नहीं भरा जिया रे ओ घर बिना लगे नहीं भरा जिया रे प्यार की कलियां कब की रखिया यहाँ वहाँ तक तक मेरे तकिया प्यार की कलियां कब की रखिया यहाँ वहाँ तक तक मेरे तकिया साझ सवेरे देखन लागे साझ सवेरे देखन लागे हरी दूर दिया हमारी अखियों पिया रे 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 दर बिना लगे नहीं भरा जिया रे हो दर बिना लगे नहीं भरा जिया रे ओ ना 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 थारी कैसा जादू किया रे ना 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 थारी कैसा जादू किया रे दर बिना लगे नहीं भरा जिया रे हो दर बिना लगे नहीं भरा जिया रे हो दर बिना लगे नहीं भरा जिया रे हो दर बिना लगे नहीं भरा जिया रे Thank you so much. আমরা জুবিনদার ট্রিবিউটে কিছু করছিলাম বিকজ দেন দিস এন্টায়ার থিং গেটস টু আ ডিফারেন্ট থিং আজকে একটা খুব মানে ভালো জায়গাতে এসেছি আমরা উই কাম টু গ্যাদার গুড মেমোরিজ সো লেটস জাস্ট কিপ ইট দ্যাট ওয়ে
सखी शाबाश कलंदर दमादम मस्त कलंदर अली का पहला नंबर दमादम मस्त कलंदर सखी शाबाश कलंदर ओ लाल मेरी ओ लाल मेरी चार चराग तेरे वरण हमेशा चार चराग तेरे वरण हमेशा पंजवा में वारण आयो बना झूले नारण ओ पंजवा में वारण ओ पंजवा में वारण आयो बना झूले नारण सिंदरी सखी शाबाश कलंदर दमादम मस्त कलंदर अली का पहला नंबर दमादम मस्त कलंदर सखी शाबाश कलंदर ओ लाल मेरी ओ लाल मेरी हिंद सिंध पीड़ा तेरी नौबत बाजे हिंद सिंध पीड़ा तेरी नौबत बाजे नाल बजे घड़ी नाल बना झूले नालड़ ओ नाल बजे ओ नाल बजे घड़ी नाल बना झूले नालड़ सिंदरी सेवड़ सखी शाबाश कलंदर दमादम मस्त कलंदर अली का पहला नंबर दमादम मस्त कलंदर सखी शाबाश कलंदर ओ लाल मेरी पत रखियो बना झूले नालड़ सिंदरी सेवड़ सखी शाबाश कलंदर दमादम मस्त कलंदर अली का पहला नंबर दमादम मस्त कलंदर सखी शाबाश कलंदर दमादम 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 Thank you so much. Thank you.
अगर डुएट गाना गा रहे हैं तो this is one song which has to be there. This is nostalgia, this love, this is romanticism at its peak in the 90s.
चाहे तुम कुछ ना कहो मैंने सुन लिया के साथी प्यार का मुझे चुन लिया मैंने सुन लिया।
पहला नशा पहला खुमार, नया प्यार है नया इंतजार, कर लूं क्या अपना हाल, दिले बेकरार तेरे दिले बेकरार, तू ही बता। पहला नशा पहला खुमार, उड़ता ही फिरूं इन हवाओं में कहीं, या मैं झूल जाऊं इन घटाओं में कहीं। उड़ता ही फिरूं इन हवाओं में कहीं, या मैं झूल जाऊं इन घटाओं में कहीं। एक कर दूं आसमां और ज़मीन, कहो यारो क्या करूं क्या नहीं। पहला नशा पहला खुमार, नया प्यार है नया इंतजार, कर दूं मैं क्या अपना हाल, है दिले बेकरार मेरे दिले बेकरार, तू ही बता। पहला नशा पहला खुमार।
उसने बात की कुछ ऐसी रंग से, सपने ले गया वो हजारों रंग के। उसने बात की कुछ ऐसी रंग से, सपने ले गया वो हजारों रंग के। रह जाऊं जैसे मैं हार के, और छूए वो मुझे प्यार से। पहला नशा पहला खुमार, नया प्यार है नया इंतजार, कर लूं मैं क्या अपना ऐ दिले बेकरार, मेरे दिले बेकरार, तू ही बता।
तू ही बता,
तू ही बता।
Thank you. Yeah, yeah.
B. 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 रात बाकी बात बाकी होना है जो हो जाने दो रात बाकी बात बाकी होना है जो हो जाने दो देखो ना सोचो तो देखो हम जाने जा मुझे प्यार से देखो ना सोचो तो देखो हम जाने जा मुझे प्यार से रात बाकी बात बाकी होना है जो हो जाने दो ला ला ओ कश्ती जवा दिल की तूफान से टकरा गई मंजिल मोहब्बत की हम तो करीब आ गई कश्ती जवा दिल की तूफान से टकरा गई मंजिल मोहब्बत की हम तो करीब आ गई देख ले है क्या मजा दिन हार गए रात बाकी बात बाकी होना है जो हो जाने दो ओ तो घड़ी नहीं यहाँ जाने क्या होगा जो हमेशा था मेरा फिर मेरा होगा कौन किसके दिल में है फैसला होगा फैसला है ये जीत होगी मेरी ओ दीवारों को अब तक नहीं है ये पता आज की रात होना क्या होना क्या होना क्या शाम है जाम है और है नशा तन भी है मन भी है बिखरा हुआ छाई है रंगीनिया फिर भी है बेताबिया तू धड़कता है दिल क्यों ये कहता है दिल ओ दीवानों को अब तक नहीं है ये पता आज की रात होना है क्या होना है क्या होना है क्या आज की रात होना है क्या होना है क्या होना है क्या Thank you so much. Thank you. Thank you.
One, two, three. But now. Double. 1, 2, 3, 4. बचना ए हसीनो लो मैं आ गया अरे बचना ए हसीनो लो मैं आ गया हुस्न का आशिक हुस्न का दुश्मन अब आधा है यारों से जुदा बचना ए हसीनो लो मैं आ गया अरे बचना ए हसीनो लो मैं आ गया हुस्न का आशिक हुस्न का दुश्मन अपनी अदा है यारों से जुदा हो दुनिया में नहीं है आज मेरा सा दीवाना प्यार वालों की दुआ में है मेरा ही तराना सबकी रंग भरी आंखों में आज चमक रहा है मेरा ही नशा बचना ए हसीनो लो मैं आ गया अरे बचना ए हसीनो लो मैं आ गया जान मिलते हैं आदम से शान देती है सलामी गीत झुकते हैं लबों पे सांस करती है गुलामी कोई पग जाया हो बादशाह आज तो कभी है मुझसे जुदा बचना ए हसीनो लो मैं आ गया अरे बचना ए हसीनो लो मैं आ गया हुस्न का आशिक हुस्न का दुश्मन अपनी अदा है यारों से जुदा थैंक यू
दीवाना दीवाना प्यार का परवाना आता है मुझको प्यार में जल जाना मुश्किल है प्यारे तेरा बच के जाना ये मेरा दिल प्यार का दीवाना 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 प्यार का परवाना चाहे जिसे चाहे जिसे उसे पाए प्यार वो प्यार के जो नाम भी मिट जाए दिल को चाहे जिसे उसे पाए प्यार वो प्यार के जो नाम भी मिट जाए जान के बगल में जान लो ये मेरा दिल प्यार का दीवाना 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 प्यार का परवाना ला 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 तू है वही तेरे जिसे अपना कहा तू है जहाँ मैं हूँ वहाँ अब तो ये जीना तेरे पे है सदा ओ मिल जाए इस तरह तो लहरे जिस तरह ओ मिल जाए इस तरह तो लहरे जिस तरह फिर होना जुदा ये वादा रहा ये वादा 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 ये वादा
ये वादा तेरे ही दम से होगी दिल की मुराद पूरी तेरे बगैर जानम है जिंदगी अधूरी है मेरी हंसी अब न जा कहीं मेरी जिंदगी
आना ही पड़ा सजना जालिम है जिसकी लगी हो आना ही पड़ा सजना जालिम है जिसकी लगी
तेरे सनम पर मिटेंगे हम मेरी जिंदगी
आना ही पड़ा सजना जालिम है जिसकी लगी हो आना ही पड़ा सजना जालिम है जिसकी लगी यार जिंदगी है बंदगी है जिंदगी है जिंदगी है याला याला ओ या अल्लाह याला याला ओ या अल्लाह मैं एक डिस्को 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 तू एक डिस्को 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 मैं एक डिस्को तू एक डिस्को दुनिया है एक डिस्को डिस्को एडिटू डिस्को एडिटू डिस्को एडिटू Lisa, 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 Marire, Rama, 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 Marisa, Lisa, 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 Marire, Rama, 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 मेरा दिल गायचा सुबी 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 मस्ती में गायचा